distinguished speakers, respected guests, and all participants. Good morning and welcome to the 7th Bethesda Yakkum International Conference and Research entitled Enhancing the Quality of Life for Stroke Patients Through a Multidisciplinary Approach, Synergy of Medical Care, Therapy, and Rehabilitation. My name is Yogyakarta Pramaista, the second year student of Physiotherapy Study Program of 7th Bethesda Yakkum. It is such a pleasure for me to be the master of ceremony of today's event and to be able to welcome you all this morning. It's amazing that today we have so many of you joining us from across the globe. Whether you're tuning in from Indonesia, Malaysia, Taipei, Netherlands, or even beyond. Ladies and gentlemen, let me go over a few important rules and guidelines for today's seminar. First, please ensure that your Zoom name is formatted as full name without title underscore institution. I repeat, full name without title underscore institution. Second, we kindly ask that all participants remain present for the entire durations of the seminar, from beginning to the end. Partial attendance may impact your eligibility for full participation. The participants are required to complete both the registrations and evaluation forms. Please note that any issues caused by incorrect data will not be the responsibility of the organizing committee. Fourth, the participants should wear appropriate attire during the seminar. Fifth, audio will remain disabled unless permission is granted by the organizing committee. Sixth, if you have any questions for the speakers, please type them in the chat feature using the following format: name underscore country underscore speaker underscore your questions. Last one, an evaluation link will be provided 30 minutes before the seminar concludes. So please be reminded that those who do not complete the evaluations will not be issued a certificate. Ladies and gentlemen, allow me to remind you to start pembelajaran pelataran sehat.
Iki speaker mama kok koyo ngene iki apa piye?
Nanti gede ini.
Today's event is a great collaboration between 7th Bethesda Yakkum, Yogyakarta, co-hosted by 7th Jayapura. Also, I'd like to take a moment to express our sincere gratitude to the following sponsors for their generous support who have made this event possible. They are Bethesda Hospital Yogyakarta, Ngesti Waluyo Hospital Parakan, Panci Wiloso Dr. Cipto Hospital Semarang, Emmanuel Hospital Klampok Banjarnegara, Sinar Kasih Hospital Purwokerto, Gria Usada Sahabat Kesehatan Anda, Dr. Julius Chandra Adi Purwadi, SPPA, SUSPP UAK, a pediatric surgeon specialist at Bethesda Hospital Yogyakarta, Dr. Handoyo SPPSK, a neurosurgeon at Bethesda Hospital Yogyakarta, Dr. Rizaldi Taslim Pinson, MKes SPN, a neurologist at Bethesda Hospital Yogyakarta, Dr. Prasetyo Trikuncoro, SPS, a neurologist at Emmanuel Hospital Klampok, Banjarnegara, Dr. Dias Irawan Prasetya, a general practitioner at Bethesda Hospital Yogyakarta. Bebek dan ayam ungkep pawon ayu by Dr. Muhammad Rifan Maulana, SPA, a pediatrician of Hospital Klampok, Banjarnegara. We are deeply grateful for your partnership and we look forward to continuing this journey with you. Ladies and gentlemen, we are thrilled to be able to connect with professionals, experts for improving the lives of stroke patients. Today's seminar promises to offer valuable insights into the critical role of collaborations between medical care, therapy, and rehabilitations, and how a multidisciplinary approach can significantly enhance recovery outcomes. So, to begin our seminar, let us take a moment to center ourselves and invite God's presence into our seminar. I kindly ask you all to bow your heads and join me in a prayer as we seek His guidance throughout our discussions today. I will lead the prayer in a Christian way. For those who have different beliefs, I kindly support us in your prayer. Let us pray. Heavenly Father, we thank you for this opportunity to come together virtually to share knowledge and wisdom with one another. We ask for your presence to guide us as we discuss ways to enhance the quality of life for stroke patients through collaborations in medical care, therapy, and rehabilitation. We pray for the speakers, the participants, and everyone involved in this important work. May our hearts and mind be open to your guidance, and may our efforts bring healing, hope, and restoration to those in need. In Jesus' name we pray. Amen. Ladies and gentlemen, to commence the event, we will have the opening performance from the student of 7th Bethesda Yakkum, who will perform a wonderful traditional dance. So please welcome Golek Ayun Ayun. Ladies and gentlemen, allow me to invite you to take a moment to honor the Republic of Indonesia by singing our national anthem, Indonesia Raya. I kindly invite all participants to rise, if you are able, and join us in singing the anthem to show respect and unity with Indonesia. Let us all stand as we listen and sing together. Thank you. You may take your seats. Ladies and gentlemen, allow me invite the chairman of the organizing committee who has been deeply involved in the planning and coordination of today's seminar to deliver his opening speech. Yogi Anggoro Putra Eskap, the screen is yours.
Thank you, MC. Good morning, distinguished guests, speakers, participants, and dear colleagues. My name is Yogi Anggoro Putra. It is an honor for me to speak on behalf of the organizing committee. First and foremost, allow me to welcome you all to international seminar. In today's seminar, we will have a discussion on the management of strokes, both bleeding and non-bleeding strokes. In neurology, stroke is a disease that often occurs at levels of society. In this case, it is very important to know the role of all parties in the management of strokes, from the initial attack to follow-up care. I would like to express our deepest appreciation to all of our esteemed speakers. Your contribution will undoubtedly make this event a memorable and enriching experience for all attendees. I would also like to take a moment to thank the Faculty of Health of Gajah Mada University and the Ministry of Health who support the realization of this seminar. Another appreciation goes to the head of 7th Bethesda Yakkum, Mrs. Nurlia, and the faculty members, Mrs. Ati, Mrs. Indah, Mrs. Indra, and all lecturers for supporting and guiding us. The last but not least, all the organizing committee of nursing education profession batch 22, 23, and 24 who have worked together in preparing this international seminar. You are amazing. To our attendees, I encourage you to take full advantage of this opportunity to engage with our speakers, participate in discussion, and network with fellow professionals and academics. In closing, I wish you all an aspiring seminar. Together, we are creating a space for meaningful dialogue that will have a lasting impact. Thank you. I hand over to screen to the MC.
Thank you, Yogi Anggoro Putra Eskap, for the welcoming speech. Ladies and gentlemen, now I would like to invite the chairman of 7th Bethesda Yakkum to give us her welcoming speech. To Mrs. Nurlia Ikaning Tias Eskap Nurse MCup SPCup MB PhD NS, the time is yours.
Thank you, Mas Ikonya. Could you hear my voice?
Yes, ma'am.
Okay. Good morning, everyone. Thank you for the opportunity to make a moment to extend a warm welcome to everyone on this special occasion. The esteemed guests, DRA Penny Rahayu MM from the board of Yakkum, the distinguished speakers, Dr. Dusaldi Taslim Pinson MKes, SPN from Bethesda Hospital, Indonesia, Associate Professor Dr. Muhammad Haizir Abdul Manaf from University Technology Mara, Malaysia. Good morning, Dr. Haizir. Dr. MGN Mulyaseh, SCAP and SMCAP SP KMB from Brain Center Hospital, Indonesia. Mr. Kondawi Joseph Banda, MSRNM PhD from Kamusu Central Hospital, Malawi. Dr. Bianca Bukci, PhD MSCN from Rotterdam Structure Service, Netherlands, and all participants. On behalf of 7th Bethesda Yakkum, it's my honor to welcome you to our international seminar entitled Enhancing the Quality of Life for Stroke Patients Through a Multidisciplinary Approach, Synergy of Medical Care Therapy and Rehabilitation. This event brings together healthcare professionals from across the globe, united by our shared goal of improving the life of the stroke patients. Today, we will explore the critical roles that medical care, therapy, and rehabilitation play in enhancing recovery outcomes with a focus on a holistic, multidisciplinary approach. We are thrilled to have such a distinguished group of speakers and participants, and we hope that today's discussion will inspire new insight, foster collaboration, and contribute to the advancement of stroke care. On this occasion, I would like to express my gratitude to all partners who supported this seminar. Thank you for joining us, and I look forward to a productive and engaging seminar. Wishing you all a fruitful session. Thank you.
Thank you, Mrs. Nurlia Ikaning Tias SPCup Nurse MCup SPCup MB PhD NS, for the welcoming speech. Ladies and gentlemen, coming up next is the welcoming speech from the board of Yakkum, the Christian Foundation for Public Health. To Mrs. DRA Penny Rahayu MM, the time is yours.
Thank you, Mas Arka, for this screen and time. To the head of the College of Health Sciences of Yakkum, Ibu Nurlia, to all the distinguished speakers, Dr. Risa Dipinson, Dr. Annie Mulyatsih, Dr. Hadsir Manaf, Mr. Joseph Banda, and Dr. Bianca Buick, and all the honored participants. Good morning and welcome to this significant gathering. It's a great honor for me as the Vice Chief of the Board of Yakkum to open this international seminar on enhancing the quality of life for stroke patients through a multidisciplinary approach. Everybody here, I believe, is accustomed to knowing that stroke has become a global health crisis. The WHO states that stroke is the second leading cause of death worldwide, claiming approximately 6.5 million lives each year. And in Indonesia alone, the burden of stroke is particularly alarming and affecting over 2.5 million people. So we are talking also about the financial strain, which is equally significant on stroke-related medical expenses, rehabilitation, and long-term care. And beyond the economic cost, stroke impact families, reduces productivity, and it's a challenge to our healthcare system to provide adequate post-stroke care, not only for the survivors, but also for the surroundings. So this seminar is not merely an academic discourse, I hope, but it's a call to action. Our objective is clear: to enhance the knowledge of multidisciplinary health workers, including doctors, nurses, physiotherapists, and other specialists, so they can work collaboratively to improve the quality of life for stroke survivors. Because the journey after stroke is long and complex, requiring not just medical intervention, but also holistic rehabilitation strategies that address physical, emotional, and social well-being. So by fostering collaboration and knowledge exchange, we aim to break down barriers between disciplines and create an integrated approach to stroke care. A patient-centered approach that combines medical expertise, advanced rehabilitation techniques, and compassionate caregiving is the only way forward if we are to offer real hope to those affected by stroke. So here I encourage all participants to engage actively, share insights, and contribute to meaningful discussions. Let's use this seminar as a platform to strengthen our collective efforts in making a real difference in the lives of stroke survivors. With that, I officially declare the seminar open. May our time together be productive, enlightening, and inspiring. Thank you, and may God bless our good efforts. I give back the screen to the moderator. Good morning.
Thank you, Mrs. Daerah Penny Rahayu MM, for the welcoming speech. Ladies and gentlemen, we are incredibly fortunate to have an esteemed group of experts from around the world with us today. Each of our speakers brings a unique perspective from their respective areas of expertise, and we are eager to hear the insights they will share today. They are Dr. Rizaldi Taslim Pinson, MKes SPN, from Bethesda Hospital, Indonesia, Associate Professor Dr. Muhammad Haizir Abdul Manaf from University Technology, Mara, Malaysia, Dr. MG Mulyatsih, SPK Nurse MKep SPKMB from Brain Center Hospital, Indonesia, Mr. Konwani Joseph Banda, MSN, RNM PhD from Kamuzu Central Hospital, Malawi, Dr. Bianca Yvonne Beuk, PhD, MSCN from Rotterdam Stroke Service, Netherlands. Ladies and gentlemen, we come to the main agenda of this international seminar. To lead the discussion, let me invite a friend of mine, Lydia Nathania, as the moderator. Lydia is a nursing student and currently in her final year of education. Hi Lydia, how's life?
Hi, Eko. Life is good. Thank you. How's yours?
It's always going well. Are you ready to lead our discussion this morning?
I cannot wait. Let's just do it.
It's amazing. I'll hand it over to you to kick things off and guide us through today's session. Over to you, Lydia.
Okay. Thank you, Eko. Good morning, everyone. My name is Lydia Nathania, and I will be your moderator in today's international seminar. It's a pleasure to be here with all of you today. Now, let's get started. We have an exciting agenda lined up, and we'll be tackling enhancing the quality of life for stroke patients through a multidisciplinary approach, synergy of medical care, therapy, and rehabilitation. As we progress, please feel free to engage with us by submitting your question, and we'll be sure to address them during our Q&A sessions later on. You may type down your question in the chat box with the following format: your name underscore country underscore speaker underscore question. Before we dive into today's exciting plenary session, I would like to let you all know that in the end of this session, we will be holding a door prize giveaway. To make this even more fun, the winner will be selected based on your active participation throughout the session. Therefore, be sure to engage with us in the discussion, ask questions, share your thoughts, and contribute to the conversations. The more involved you are, the higher your chances of winning. The first speaker we have is Dr. Rizaldi Taslim Pinson, MCAS SPN from Bethesda Hospital, Indonesia. He will discuss about collaborative strategies to empower stroke recovery from a medical perspective in Indonesia. Good morning, Dr. Pinson.
Good morning, Lydia.
Okay,
Good
how
morning,
are you
everyone.
today?
I'm fine, thank you. I hope all the
Okay.
audience fine also.
Okay, thank you so much for taking the time to join us and for sharing your expertise today.
Yeah, it's a great honor for me.
Yes, lovely. Before we start, I would like to take a moment to introduce Dr. Pinson by showing you a video CV that highlights his accomplishment and journey. Okay, we're all excited to hear your thoughts and expertise on the subject. You have approximately 30 minutes to present your topic. Dr. Pinson, the floor is yours.
Thank you very much for the kind introductions. I have recorded my presentation for the for this event. Okay, Mas Irun, can you help me? Pak Irun, tolong bantu di share. Thank you very much.
Kind introductions. It's a great honor to be part of this prestigious meeting. My topic of discussion is collaborative strategies to empower stroke recovery from the medical perspective. This is my curriculum vitae. And to all the audience, there will be a small quiz. Please answer in the chat or in the Q&A. Do not worry, this is not a Squid Game. So there is no right or wrong answers. This quiz is only for fun interactions between us. Stroke definitions. Most common stroke definition is an episode of acute neurological impairment. So the patient will come to us with acute neurological impairment, the weakness, the speech disturbance, unconsciousness, acute cognitive deficits that thought be brought on by hemorrhage or ischemia. lasting longer than 24 hours or until death. So the problem is on the brain's circulations, and it is caused by hemorrhage or ischemia. Please answer is a yes or no, A or B. Stroke is the leading cause of death, bankruptcy, and disability. Please answer it in the chat or in the Q&A forum. Yeah, thank you very much for your kind and active participations. Yeah, the right answer is yes. Stroke, either ischemic and also hemorrhage, is a leading cause of death, a leading cause of disability, and also leading cause of bankruptcy. The mortality rate of stroke is commonly between 10% to 20% across the regions. And among the stroke survivors, there is a mild, moderate to severe disability. Disability will impact with a poor quality of life and also leading cause of bankruptcy. This is the data in Indonesia. When you see the data, there is nothing changed in the past 10 years. Between 2009 until 2019, that stroke is still the #1 cause of deaths in Indonesia. The cause of death is almost 25% in Indonesia. So in this case, I think we must work together, learn together to improve this condition in the future. Another quiz, please answer. What is the commonest type of stroke? A, intracerebral hemorrhage, B, subarachnoid hemorrhage, C, cryptogenic stroke, D, small vessel disease, or E, embolic stroke. There are many category or subcategory of stroke based on the causes and the pathomechanisms. Please answer, what is the commonest type of stroke? A, B, C, D, or E. In most cases, stroke is ischemic. And there is a subcategory of ischemic stroke, large vessel, small vessel, embolic, or undetermined. The answer of this quiz is cryptogenic stroke. If you can see in these diagrams, in most cases, stroke is ischemic. Almost 85% of stroke is ischemic. Only about 15% of stroke is hemorrhage, either intraparenchymal or subarachnoids. Between the ischemic stroke, there is a large vessel disease or large artery disease, penetrating or small vessel disease or lagoon, and there is also cardiogenic embolism. So the source of the emboli is from the heart, from the cardiacs. In most cases, the main risk factor is atrial fibrillations, or in some cases, a valve disease. And the other, the most common, is the cryptogenic stroke. It means that the major mechanisms is undetermined yet. We have to find the causes. So it is not related with the large vessel, not related with the lagoon, not related with the cardioembolisms. And the others, about 5% cases, is unusual cases. For example, in patients with prothrombotic states, thrombocytosis, dissection, arthritis. If you have a young patient, especially female with migraines, she is a really high risk of stroke, especially migraine with aura. So in this kind of patients, we must prevent by telling the patients to prevent the migraine. And if it is a child bearing good age, we have to tell the patient that must avoid oral contraceptive medications, because the use of oral contraceptive with migraine with doubling the risk of stroke. And another causes is drug abuse and many more. This is the common stroke mechanisms. Whatever the mechanisms, especially in the ischemic stroke, the aim of stroke management is to prevent further brain damage. Mortality, enhance recovery, maximize independence, and if we can maximize the independence, we can reduce the disability. The cost of the treatment will be more efficient and also less complications. If you can see the figures, please imagine that the red one is the brain damage area. The green one is the brain area that can be resolved by a certain treatment. And then if you can see that the aim of the stroke management especially is to prevent the brain damage, the secondary brain damage. If you compare between 10 minutes, 1 hour, 3 hours, and 6 hours, the damage of the brain area will prevent the brain damage in the early phase of stroke. We have the core brain damage, we have the penumbra. Penumbra means that this is the area of the brain that can be saved with a certain approach, certain medications, and also teamwork. If you can see the figure, you can compare the brain damage in the white area between 5 hours, 13 hours, 1 day, and 2 days. If we do not treat it as early as possible, we do not treat it properly, the area of brain damage will increase over time. So we have to work together, especially in the very, very limited time, to prevent further damage. If we can prevent further damage in the brain area, we have a more chance to get less disability. The patient have more chance to come back to their daily activities. The patient have more chance to improve the quality of life. And the patient also have more chance to prevent the patient and the family to bankruptcy. This is another quiz. Please remember, this is not a squid game, so please answer it. Stroke is complex conditions and need multidisciplinary approach. Yes or no? Please answer. Yes or no? Thank you very much for your very kind participation. I think this answer is yes. That's why, Bulia, thank you very much, and 7th Bethesda do these very fruitful international seminars, because we have to work together. We have to cooperate for the stroke management. Stroke is a very complex condition. The risk factor is vary. The symptoms is also vary. The sign is also vary. It means stroke is a complex condition. The complexity of stroke, especially in diagnosis and treatment, necessitate a seamless integration of expertise from various healthcare. I think the next speakers will tell us more about their perspective, the healthcare professional perspective. I am, as a physician, think that this is a very important. We must work together with a fruitful cooperations for the good of the patient and the family. Who involved in the care? If you can see in these complex conditions, many healthcare professionals, neurologists, radiologists, nurses, therapists, physical therapists, occupational therapists, speech therapists, pharmacists, social workers will work together to prevent death, to prevent disability, to increase the quality of life of the stroke patients. This is the patients from the admissions to the discharge. There is a very complex activities, and the complex activities need us to have a collaborative communications between all the healthcare professionals, between the physician, between the nurse, between the pharmacist, and also the physical therapists, social workers, speech therapists, everybody that work as a team. We have to work as a team to improve the outcome, to prevent the adverse event. So, as a team, we have to determine our care objective. The care objective of stroke patient is less mortality, less disability, short-term time in hospital stay, and also more efficient treatment. After that, the team must construct care plans. That's what we call pathway, the care pathway, from the admission to the discharge. The team has worked together to conduct treatments, either medications or non-medication. For example, physical therapies, speech therapies. And then we have to identify the risk of the patient. The patient can get multiple complications because of the immobility, because of the dysphagia. For example, if we do not perform dysphagia screening in the beginning, that can be performed by nurses, by the physical therapist, by the speech therapist, and by the physician, we can get pneumonia. And pneumonia in stroke is the leading cause of death and also disability. So identifying the risk and outcome is also very important. In this figure, we are a team. We are a team that take care of the patient with stroke with the multidisciplinary approach, work together to ensure that the patient have a good outcome. If you can see in this figure, our aim of treatment to treat the brain. If we can treat the brain well, we can enhance the recovery of the patients. And if you can see the figures, there are so many professionals, the physician, the nurses, the therapists, the physical therapists, occupational therapists, speech therapists, dietitian, and also pharmacists. We work together to make sure that we can give the patients the benefit. We can give the patient the most appropriate treatment to prevent death, to prevent disability, and have more benefit for the patients. So this is stroke care team. We cannot work alone. Effective stroke care lies on the collaborations of multidisciplinary teams. That is my medical perspective. We cannot work alone. If we want a better outcome, better stroke care, so we must work together as a team. Then everybody, its member, brings their special knowledge and skills that crucial for comprehensive patient care. I'm a physician, diagnosis and give medical treatment. The nurse is very important for the diagnosis of the need of the patient. Get a very good nursing care. Pharmacist will give us his or her idea about the appropriate treatment and also to manage the medication. Then the medication in stroke patient can be very complex because of the risk factor. The physical therapies play very important role to prevent disability from early phase of the stroke care. The dietitian is also very important. Speech therapies in patients with speech disturbance, aphasia, and also occupational therapies to make sure that the patient can perform their daily activities after stroke. So in my medical perspective, we have to work together. Effective stroke care need a collaboration, multidisciplinary teams. If you can see this figure, stroke patients, either hemorrhage or ischemics, and also the family and caregivers need us to work together. Why? The stroke patient can have various symptoms, various signs, various needs, and also various expectations. That's why in the hospital, we must have a good care pathway from the beginning in the emergency room until the discharge. The pathway of the multidisciplinary approach need us as a team to work together. And this multidisciplinary approach will optimize the outcome, optimize the care. From the screening and assessment of the patient, treatment plan, team-based care, and we must ensure it work to achieve our target goals. And we must work together continuously for the quality improvement of our care. If you can see, this is a very complex stroke care structure. Stroke care structure need a care policy from the management. If we can take care the patient in the stroke unit, the outcome will be better. If we can give certain medication for RTPA, the outcome will be better. And it needs, we work together. For example, for RTPA, it is very important for diagnosis. The time is very critical. So we must work together between physician, the radiologist, the nurse after the procedure, and also the pharmacist for the medication preparations. We must work together as a multidisciplinary team. In the stroke care process, the assessment of the patient, the assessment of the need of the patients, the assessment of the nursing care of the patient, and also the rehabilitation process that need physical therapies, speech therapies, occupational therapies. We must work together. We must work together to ensure the patient have a good nutrition, good diet, good physical therapies. And then we can get the best outcome after discharge. After discharge, we must work together also to make sure that the patient is functional independence, have a shortened length of stay in the hospital, less mortality, can come back to their daily activities, and also improve the quality of life of the patient. So, if you can see in this figure, the complex treatment from the beginning in the emergency room until the patient discharge is a very complex condition. In this very complex condition, there are many various healthcare professionals that involve, and we cannot work alone. We need multidisciplinary approach. For example, in the emergency room, history taking, physical assessment, the diagnosis, the early treatment, need various healthcare professional collaboration. The physician, the nurse, the radiologist must work together. The pharmacist must work together. And then the patient go to the radiological suite and then laboratory suite. We can get the diagnosis, either ischemic or hemorrhage. We can get the information about the risk factor from the laboratory test. And the patient will go to the stroke ward, to the stroke unit. Neurological assessment will be performed, nursing care will be performed, medicines, early rehabilitation, and also education. In this stroke ward, in the stroke unit, we must work together. Good communication between us as a team is very important. And there are many evidence, many studies that mention that good multidisciplinary approach from the beginning until the patient discharge will improve the outcome. After discharge, the patient will go to outpatient clinic. We still have to work together, to collaborate together with the physical therapist, with the occupational therapist, with the speech therapist, with the pharmacist, to ensure that the patient get the best medication, best treatment, best rehabilitation process to ensure that the patient can come back to their daily activities and have a good quality of life. So, when treating the patient, either in the acute phase, subacute phase, rehabilitation, and also home phase, we must work together. If you can see in this figure, in the emergency room, in the acute phase, in the wards, we have a history taking, physical assessment, diagnosis, early treatment, early rehabilitation that need us to communicate each other, to respect each other, to know the rule and expertise of each other. With that mutual respect and understanding, we can work together. In the subacute phase and rehabilitation, the patient needs nursing care, medicines, early discharge planning, and also rehabilitation. We must work together also, communicate about the best diet, the best medicine, the best rehabilitation program. In the home phase, the patient must visit us in the outpatient clinic to ensure that the risk factor was controlled, to ensure that the medication was taken appropriately. And he or she will continue the rehabilitation process, the physical therapy, the speech therapy, the occupational therapy, to make sure that he or she can come back to their daily activities, independence, and improve the quality of life. Why we have to work as a team in stroke care?
Excuse me,
A,
sir.
improve outcome. B, less complications. C, more effective. D, more efficient. Or E, all above. Please
I'm sorry, Dr.
answer
Vincent.
this question.
I'm really sorry to interrupt you.
Thank you very
But-
much for your
I
very
would
kind
like-
participation. Yeah, the answer of this question is certainly E, all above. Work as a team. Previous studies underscore the significance of such teamwork in improving patient outcome. For example, this is a systematic review that mentioned that multidisciplinary team working as a fundamental in delivering effective care in the stroke pathway. And it's highlighting it's important it maximize the effectiveness and efficiency of the rehabilitation process. So we must work together in the CaRe pathway program. This is our old studies about the clinical pathway. If we work together as a team with a good pathway, then our study show that the clinical pathway is improving the indicator of stroke care services. This is another study, the effect of clinical pathway implementation and the length of days of strict ischemic stroke patient in Indonesia. And the analysis showed that the multivariate analysis found that clinical pathway, a good clinical pathway with a multidisciplinary care pathway, significantly reduced the risk of hospitalization length more than 8 days by 53%. It is a significance. And how about the efficiency? If you can see in our studies that the role of clinical pathway on the outcome of ischemic stroke patients at Bethesda Hospital Yogyakarta, if you can see in the table that the cost of treatment is less in the clinical pathway program. So clinical pathway program can lead us to less complications, to more independence, and also less costly services. So work as a team. The collaboration of multidisciplinary team is very important, where each member brings specialist knowledge and skills that are crucial for comprehensive patient care. And this model is advocated by many international organizations and guidelines. So we must work together. Integration of diverse expertise for optimal stroke recovery. What are the barriers of multidisciplinary work in stroke care? A, arrogancy. B, lack of understanding. No communication, system care, or all above. Please give your best answer. Yeah, I think the answer is A, all above. So, multidisciplinary approach not only ensure a holistic treatment plan, but also foster a supportive environment to conducive to patient and caregiver engagement in the rehabilitation process. So if we work together, we will meet the patient and caregiver needs. This is the very important components. Understand, competence, credible. So we must understand everybody rules. Everybody rules must have a good competence, credibility, and then we have a mutual respect and trust each other about each other team, rules, competence, and so credibility. Work as a team with mutual respect and understanding for everybody rules and responsibility. I will repeat again. Work as a team with a mutual respect and understanding for everybody rules and responsibility is very important. This is my medical perspective to work as a team with a multidisciplinary approach in stroke care. It will lead to less mortality, less disability, less complication, and more satisfaction. Many studies mention it. Our studies in Indonesia, in Bethesda Hospital, also show the same result. So it is a long journey for the stroke patient, and we as a team have worked together to ensure that the patient and the caregiver can meet their need in this long journey. So collaborative care model with a patient-centered care is a very important. Working together is very important for better patient care and outcome. That's what we call comprehensive stroke care services. Mutual respect and understanding will meet the patient need. It will cause less mortality and morbidity. In the mutual respect and understanding to work as a team, we must understand everybody's role and work together. This is the conclusions. Stroke is the major health problem. Increased awareness, treatment compliance, and optimal prevention are mandatory. In my perspective, in my personal perspective, in my humble opinion, collaborative care with mutual respect and understanding is very important for optimal management in all levels. The collaborative care improves the patient outcomes. Thank you very much for your very kind attention. I will see this quote: coming together is a beginning. Keeping together is progress, and working together is success. Thank you very much for your very kind attention. I would like to thank the committee for this honor. Thank you very much.
Okay, thank you to Dr. Pinson for sharing your expertise to us this morning. Please stay in this room because we will have a Q&A session after the second speaker session. Thank you, Doc. Dear participant, if you have any question for Dr. Pinson, you might type down your question in the chat box in the following format. Your name underscore country underscore speaker underscore question. Dr. Pinson will answer the question in the first Q&A session. Okay, coming up next, we have Associate Professor Dr. Muhammad Haizir Abdul Manaf, PhD PT from University Teknologi Mara, Selangor, Malaysia. This morning, he will tackle collaborative strategy to empower stroke recovery and rehabilitation from a physiotherapist perspective in Malaysia. Good morning, Dr. Haizir. Can you hear me?
Yeah, good morning.
Okay, good morning. How are you, sir, this
Hi,
morning?
thank you. Sorry for the delay.
Okay.
So you can hear my voice clearly?
Yes, loud and clear.
Loud and clear, thank you.
Okay, thank you so much for taking the time to join us and for sharing your expertise today. But before we get started, I would like to invite you all to watch a short video that showcases Dr. Hadzir's impressive achievement and expertise. So let's take a moment to watch the video and then we'll jump right in. Okay. Dr. Hadzir, we're all very excited to hear your thoughts and expertise on the subject. You have approximately 30 minutes to present your topics. Okay, sir, the floor is yours.
Yeah, thank you very much. First of all, I would like to say thank you to the stickers. Bethesda, am I pronounce it correct? Bethesda Yakkum from Yogyakarta, Indonesia, to invite me for this morning sessions. So my name is Muhammad Haizir Abdul Manaf. You can call me Haizir Manaf. Currently, I'm the associate professor at the University Teknologi Mara. My background, I'm a physiotherapist. I'm also currently as the president of Malaysian Physiotherapy Associations. So today I would like to present. The title of my presentation is the collaborative strategies to empower stroke recovery and rehabilitations from physiotherapy perspective in Malaysia. So as you all know, stroke is the neurological deficits that attribute to an acute focal injury on the central nervous system that is caused by vascular that can be divided into ischemic and hemorrhagic causes. As mentioned by the previous speaker, in terms of prevalence and incidence, stroke in Malaysia. So we based on data from 2009 to 2016, there are about a total of 11,284 stroke cases happen yearly. Okay. So in 2019, the Malaysian data reveal increasing trend with 47,911 incidents and about 726 in terms of their daily. So the consequences of stroke, if based on ICF model, so the consequences also will divide it into three. The main three, which is impairment, activity limitations, and also participation restrictions. So for impairments, most of the survivors were presented with motor impairment, sensory impairment also, cognitive impairment, speech language, and also the last one will be the sensory impairments. So how much that this impairment may lead to activity limitations? Most of the survivors may have difficulty in self-care, difficulty in mobility such as bed mobility, sit to stand, and also unable to perform, especially walking, and unable to perform the community ambulations. And some of them have struggled to complete single or multitask. And in terms of participation restrictions, they are unable to work, unable to return to work, inability to engage in religious activity. So for Muslim, for Christian, or for Hindu, and also for Buddhist in Malaysia, they are able to attend, or maybe to go to the religious mosque or temple of our church, because of the unable to perform certain tasks such as walking, and unable to participate in the religious activity. So in terms of that, most of the survivors also have limitations in social interactions, and are limited in terms of recreational. So in terms of stroke recovery, so stroke recovery process is time dependent. So they are been divided into few phases in terms of recovery. So the first one will be the hyperacute phase, which is during the 24 hours of the incidence of stroke. And then after that is the acute phase, early subacute phase, and later they have late subacute phase, and the last one, more than 6 months, they call it as the chronic phase. So for the hyperacute or acute stage of the stroke, so this phase is characterized by medical diagnostic and the preventions of progressive damage of the brains. And during the phase, there will be a secondary complications. So the aims of the medical managements is to start mobilizations and rehabilitation at an early moment. So means that during the early stage, once the medically declare that the patient is stable in terms of their medically conditions, then we as a physiotherapist can start mobilization during the early stage. So the next stage will be the early rehabilitations. So this phase is characterized by rehabilitation aimed at restoring functions, learning compensatory strategies, or learning compensatory movement, in order to avoid or reduce limitation of activities and restriction of participations. So during this stage, normally physiotherapy will teach the caregiver how to perform passive movement. Okay, means that we move the affected limb to make sure that the affected limb is still able to mobile or able to move, or to maintain the properties of the muscles, in order to avoid the shortening of the muscles, restrictions in terms of the joint surface. And at the same time, we will teach the caregiver how to mobilize the patients in terms of how to perform supine to side lying to sitting, And from sitting, we teach the caregiver how to perform transfer from bed to wheelchair. At least the patient can go back at home by using wheelchair in the early stage. But it depends on the certain situation, or in certain situation means that if the patient have severe motor dysfunction and also have severe activity limitations, then we can prescribe wheelchair as the ambulation. However, if the patient have a little bit of movement, very mild stroke, less complication in terms of mobility and movement, then we do not prescribe the wheelchair to the patients. However, we have to teach exercise, stretching exercise, make sure that the patient sits on the wheelchair or chair, okay, start the ambulation, sit to stand activity as soon as possible in order to avoid limitation of activity and restriction of participation. In necessary, in this stage, adaptation to the patient physical environment are implemented and home care is arranged. So the early rehabilitation stage is between after 24 hours, okay, after the acute stage, until the first 3 months. Later, after 3 months, so the phase that we call it as the late rehabilitation stage is lasting between 3 to 6 months. We still continue the early rehabilitation stage. Okay, we emphasize the prevention and reduction of limitation of activity and restriction of participation. We continue same as the first phase of the during the stroke rehabilitation stage. Okay, however, we try to increase the intensity. If necessary, we also adapt the patient physical environment, and also home care is arranged. And the last one is the chronic stage of stroke rehabilitations. Is lasting longer than 6 months. During this stage, we preserve and prevent with the aim of assisting the process of adopting, optimize social functioning and learning to cope with limitation, preserving physical fitness, and monitoring quality of life. So, for today's presentations, later on, I will go into how we as a physiotherapy can help the stroke survivors to maintain or to increase their physical fitness in order to improve their quality of life after stroke. So, this is the post-stroke care service in Malaysia. We talk about the health facilities, either it's public and private sector. So, let's say that the patients have the initial cerebrovascular event or the stroke event. So the patient will be admitted, or maybe to transfer, or maybe to admit at the medical ward or stroke unit. It depends on hospitals. Not hospital have the specific stroke unit. However, most the hospital in Malaysia have the medical ward. So there will be the patients or the stroke survivors have been diagnosed during the admissions and during the admission at the medical ward. And then most of the patient with the average length of 7.48 days. Okay, this based on previous data. They will admit at the hospital at least 7 days. Okay, in order to have the medical management to manage the stroke event. After that, once the medical is stable, okay, physiotherapists already teach the caregiver how to manage the patient, how to handle the patient at home, and the patient will be discharged. Okay, we can, or maybe the caregiver will be the spouse, the relative, or maybe they have the domestic helper. They pay for the domestic helper. If you see the arrow, okay, it depends. Okay, it depends. Some will send the patient, the stroke survivor, will be sent to the nursing home. Okay, in Malaysia we have several. They have a lot of nursing home. Then the nursing home is actually is a private nursing home that will take care of the patients at a certain at the private nursing home center, or if not, once the patient discharged from the hospital, from the medical hospital, either they will be transferred to rehabilitation hospital. Okay, it depends. In the government hospital, we have one hospital rehabilitations in Ceras, Kuala Lumpur, and then we have few private hospitals that have facilities for rehabilitations. The hospitals means that this is not the acute hospital or common hospital. This hospital is the specific for stroke, or no, sorry, the specific for rehabilitations. So means that we call it as the rehabilitation hospitals. Or if the patient don't have the opportunity to go to a rehabilitation hospital, so they will go back to the hospital, from the hospital that provide the physiotherapy services in the hospital. Most of the session will be, at least they can give is about once a week during the first 3 to 4 months of the post-stroke. However, in certain area, in certain hospital, the patient is, they have a lot of patients, too many patients. They cannot give the appointment once a week. They can provide maybe maybe once a month, or maybe 2 weeks once the appointment. Therefore, the stroke survivor will get, or maybe seek another services from the private physiotherapy, either in the center, or they call the physiotherapist to go to their house, or we call it as the locum physiotherapy, or we call it as the home-based physiotherapy. It depends again. So the arrow here shows that in Malaysia, even though that we have the hospital rehabilitation hospital that can cater rehabilitation process for the stroke survivors. However, due to the limited number of beds, so it's still, the survivors still require extra physiotherapy services. Either they go to the private physiotherapy center, or they ask the home-based physiotherapy to come to their house in order to provide the physiotherapy services. So, okay, you can see here on the left side, this is the hospital rehabilitations under Ministry of Health. Okay, this is government hospital. Okay, government funded. And then at the same time, we have private center, private hospital, rehabilitation hospital. One of it is we call it as a Tihan Rehabilitation Hospital Putrajaya. Another one, we have Region Rehabilitation Hospitals. This is private. It's very expensive. It's not all able to afford this hospital, because unless they have insurance that can cover the services in the private setting. If not, they have to go to government hospital. Other than that, we have National Stroke Association of Malaysia. They have about 5 to 6 centers in Malaysia, different states. Okay, they provide physiotherapy services for all the stroke survivors. And at the same time, I also would like to show this is our clinical practice guideline for management of ischemic stroke by Ministry of Health. And at the same time, we have Malaysian Stroke Councils that represented by medical doctors, neurologists, and also rehabilitation specialists. And then we have other allied health profession that under Malaysian Stroke Councils. Okay, this is part where I would like to share about the community-based rehabilitations in Malaysia. Okay, as I mentioned before, even though that certain hospital unable to provide the service, the physiotherapy or rehabilitation services frequently, so we have another tier level of, we have in Malaysia, we call it as the klinik kesihatan, or maybe public health clinic. maybe the terms in Indonesia is different, but yeah, we have another layer. We call it as the health center of community health. So we also send the patients, refer the patients to the clinic kesihatan in order to make sure that the rehabilitation team, PT and OT, to evaluate and manage the patients in the clinic kesihatan. Oh, sorry. So in terms of physiotherapy, okay, as a student physiotherapy, as a practitioner of physiotherapy, we are very concerned. We know about the functional mobility, our roles to improve their functional mobility in terms of bed mobility, all right, supine to start lying, okay, improve the sitting ability, able to sit prolonged sitting, able to maintain the balance, static and dynamic. So this is something that I think you have taught it in the undergraduate syllabus, okay, or diploma syllabus, okay, sit to stand, standing and walking. So this is, I will tell you that this is something that we focus for stroke rehabilitations. However, this is something that I'm not sure we are concerned about the other things, especially once the patient become the chronic stage or more than 6 months. Normally that it was reported the physical activity rate truly decline after discharge from the rehabilitation program dramatically. So means that after the 6 months, at least after 1 year post-stroke, the patient, in terms of physical activity rate is very low. Okay. So why the physical activity is very important? So physical activity is very important in order to prevent secondary negative sequel of stroke, such as pressure ulcer, infection, diabetes mellitus, and hypertension. So the benefit of physical activity for stroke patients may reduce the complications of cardiovascular disease, metabolic disorder, obesity, and hyperlipidemia. So on top of that, the effects of physical activity on stroke patients as shown is well investigated in worldwide. However, based on individual stroke patients, the specific dosage to each stroke level is still needed. So, other than that, physical activity also serves as the important agent for participation for the stroke survivors to participate in society or community. And then, again, this is different. It's based on country and to country. It was reported that the most common barriers to physical activity is due to physical impairments such as balance, weakness, and pain. This is the 3 elements or 3 symptoms that patient always tell physiotherapists why they don't want to do exercise, why they doesn't want to do the physical activity, because of the pain, because the weakness of the affected side, and also balance. Then they afraid that if they perform the exercise, they will having the high risk of fall. So another symptom that trigger the low level of physical activity is because the fatigue symptom. So some patient mentioned that the fatigue symptom may also limit physical activity. Okay, in India, it's different in India because they mentioned that transportations was a major barrier to physical activity in the most stroke survivors, because they mentioned that, let's say they want to participate in gym, participated in any exercise or activity at the community-based level, they have difficulty to go to the center because of the transportations. So it depends in country. In Malaysia, most of the barrier for physical activity is because of the fear of fall. Okay, number 2, because of the facility itself. For example, we have a recreational gymnasium in Malaysia. that, however, the the equipments in the gym is not fit or is not suitable for people with disability. Okay, for example, that some of the equipments is only meant for the healthy person rather than it can be used by the people with disability. So this is there's some barriers that why they prefer to do home-based exercise rather than they go to the community or to the gymnasium to do the exercise. So based on ACACM, American College of Sport Medicine, they mentioned about the components, another component after the stroke, not after the stroke, after during the chronic phase of stroke is the physical fitness. So you have to know that what is definition of physical fitness. As a physiotherapist, we need to know about this. Physical fitness is, according to ACSM, is have 5 components. 5 components. Number 1 will be the cardiorespiratory fitness. Number 2, muscle strength. Number 3, muscle endurance. Number 4, muscle flexibility. And number 5 is body composition. Okay, there are 5 components of physical fitness. So what do you mean by physical fitness? Physical fitness is the ability to carry out daily tasks without vigor and alertness, without undue fatigue, and with ample energy to enjoy leisure time pursuits and meet unforeseen emergency. So means that for physical fitness, maybe the words that I can use is cardiorespiratory fitness or endurance. The word is endurance, or you maybe aerobic exercise. Okay, maybe you might be familiar with the aerobic exercise. So this is the ability to perform physical activity for extended period. So in terms of musculoskeletal fitness, we have the muscle strength and we have muscle endurance. So in 2000, I'm not sure, in 2000, the recent systematic review with meta-analysis have shown that physical fitness training is the best component of exercise, especially for people with chronic stroke survivors. Okay, either we prescribe cardiorespiratory training alone or combined with resistant training element, or we call it as the mixed training, is improve the speed and the capacity of walking when the walking mode exercise is used. It means that, let's say, for example, okay, you improve the cardiorespiratory. At the same time, you improve the muscle strength of the patients. With the combinations of this exercise weekly, it improves the patient ability to walk faster and the endurance of walking. So normally that this is the component is very important to ensure that the patient able to go back to the community, or we call it as the ambulation in the community or community ambulation, to make sure that the patient able to improve the community ambulation and increase their quality of life. So how to do it? So the frequency will be between 3 to 5 days per week. So the progressions or progressively increase from 20 to 60 minutes per day, or consider multi 10-minute sessions. For example,
Sorry, Dr. Hatsir.
yeah.
I'm sorry to interrupt you, but I would like to let you know that we have 5 minutes left.
Okay, thank you. I
Thank
will
you.
finish as soon as possible. And then as a student also, or as a student or the clinicians, in order to prescribe aerobic exercise, we have to know how to calculate the maximum heart rate, or maybe you can use the heart rate reserve calculations in order to make sure that the patient follow the heart rate reserve between 40% to 70% of heart rate reserve to do the exercise. Or in the absence, if you don't know how to use it, the heart rate reserve, to calculate the heart rate reserve, then you have to familiarize with the box scale. Okay, I think that you all knows the box scale, BORG scales, that they have two versions of box scale. Number one between 1 to 10. Another version will be from 6 to 20, 6 to 20 scales. So you can choose either the first one or the second one. And the type of exercise that you could prescribe, either you're using the cycle ergometer, or you use the semi-recumbent seated steppers, or you can use treadmill. However, there is a precautions. If the patient have insufficient balance, make sure that you have the harness system in order to take care the in case the patient fall. Okay, this example of activity you can calculate using the MET, and then they have few levels. Okay, example of physical activity, the highest ranking, the highest level of exercise, vigorous physical activity. So it's a very fast walking. It's more than 7 kilo per hour. The speeds is the exercise will be the running, swimming, cycling, and everything that higher level of speed. So other than that, you can improve the patient in terms of their step daily or pedometer. You can use the pedometer. Nowadays, all the smartwatch, they have the step count, okay, step per day, how many that activity you can conduct, step per day. In Malaysia nowadays, last time it's very expensive. Now in Malaysia, it's cheap already. We have Xiaomi, the product from China. We can use the watch. So the goals is to make sure that the patient perform 10,000 steps per day. Okay, however, it's quite difficult to start as a 10,000. You can start at least at the beginning, 2,000 steps per day. Progressively progress the activity until you can reach 5,000 to 7,900 steps per day. Okay, this is the technology you can use. They are consumable grade. You have the high-end grade. However, most of the patient prefer to use Xiaomi because it's expensive. Ringgit Malaysia is about 100 ringgit in Malaysia. With that, thank you very much. This is my presentation. Thank you very much.
Okay, thank you to Dr. Hadzir for sharing your expertise to us this morning. Please stay in this room and we will directly go to the Q&A session. Thank you so much, sir. Dear participant, if you have any question for Dr. Hadzir, you may type down your question in the chat box with the following format: your name _ country _ speaker _ question. He will answer the question in the Q&A session. Ladies and gentlemen, we will open the floor to questions from our audience. The committee has collected questions for our two wonderful speakers. I will start with the question for Dr. Vincent. The question is from Mrs. Rina from Rumah Sakit Bethesda Yogyakarta. And the question is, what are the problems in implementing IPC and managing stroke patients, and how to overcome these problems so that the implementation of patient-centered care can be carried out optimally? And we are aware that you already answered the question. If you want to explain more further, please do so.
Yeah, thank you very much, Mbak Rina, for the question. I think ICP is begin with the IPE. So I think this fruitful meeting is very important because I see that many students join this meeting. If somebody never learn together, they never work together. So ICP is beginning in the process of education. In the workplace, I think if we can communicate with integrated care pathway, with a multidisciplinary approach, and everybody must understand everybody's rules, everybody's expertise with mutual understanding and respect, and we can collaborate in fruitful conditions. I have already answered it to Barina. Thank you.
Okay, thank you so much, sir, for your insight. And the second question is coming up from Maria from Indonesia. And the question is, based on your experience in treating stroke patients, what are the signs that indicate a person has the potential to develop stroke problem in the future? What should individual be aware of to taking care of themselves and the potential for stroke? Furthermore, when observing the signs of stroke, these are often some similarities with the signs of panic attack. How can we differentiate whether a patient is experiencing a stroke or not?
Okay, there are certain patients that can have higher risk of stroke. That's what we call a stroke risk factor. Stroke risk factor means elderly, male, sex, and then high blood pressure, high cholesterol level, diabetes, obstructive sleep apnea, high blood glucose, obesity, something like that. So in this kind of patient, you must be aware that stroke risk is higher. What is the symptom and sign? Acute. Acute is a very important word. If the sign and symptoms have been acute, sudden, so you must be aware that this is a stroke until we certain that it is not stroke. So what is the most common symptom and sign? Be fast, balance, eye problem, face dropping, arm weakness, speech disturbance. Be fast. If somebody have an acute impairment in speech, acute arm weakness, leg weakness, acute face dropping, then we have to tell the patient, tell the family, tell the community to go to the hospital immediately. When he or she go to the hospital after face dropping, and then the physician mention, oh, this is not stroke, it is Bell's palsy, idiopathic facial nerve palsy. It's okay. But it is better to go to the hospital immediately because we have a very limited time frame. That's what we call time is brain. Time is brain. We only have 4.5 hours to give the RTPA. So go to the hospital immediately and treat it in the stroke unit will get you to better chance of recovery. A person with stroke can have a further stroke. Controlling the risk factor is very important. How to differentiate it panic attack? It really depends on panic attacks commonly happen in the young age. Stroke happen in the elderly. So when somebody with a very young age, without risk factor, no high blood pressure, no cholesterol level, no diabetes, no smoking, and then he or she complain that I suddenly do not see anything, the physician will get the diagnosis with a very, very careful history taking and physical examination to differentiate it. But stroke happen in certain individual with risk factors. I think I have already answered all the questions.
Okay, sir. Thank you.
Thank you.
Thank you very much for your answer. And the up question is for Dr. Haitzir, and the question is from wait, okay. And the question is from Miss Rini from okay, I'm sorry. The first question is from Mr. Abram from RS Emmanuel. And the question is how to conduct initial screening for suspected stroke patient. Would you be so kind as to respond to this question, Dr. Haitzir?
Yeah, thank you very much. I think the question actually, if I'm not mistaken, he asked how to conduct initial screening suspected patient stroke. So I think this question actually already been answered by Dr. Rizaldi by using the fast or segera. So in order to lead the detections of the stroke, maybe that Dr. Rizaldi already mentions about how to check the face drooping, and then also the arm weakness, and also the speech difficulty. So this is something that we can see for the patients by using the FAST. When they have the patient have the three combination of the symptom, it's time to call for the emergency response. I think I answered the question already.
Okay, thank you so much, Dr. Haitzir, for the question. For the answer, I'm sorry. And the second question is coming up from Mrs. Maria from Stikaswaka Instan. And the question is, how does collaborative care for patients with stroke apply? I'm curious about how you work with the other health practitioners, such as doctor and nurses while treating stroke patients. Dr. Hadzir,
Okay.
could you provide your insight on this?
So in Malaysia, actually, we have call it as the multidisciplinary team in Malaysia. We have a good collaboration between previously we have good collaboration between the neurologist, medical doctor, and also the allied health professional. During early year of 2002, there are growing numbers of rehabilitation medicine specialists in Malaysia. So for me, it's very good combination between, because we have rehabilitation specialist doctor within the rehabilitation team. Other than physiotherapy, we have OT, occupational therapists. We have nurses that involve the rehabilitations. On top of that, we have clinical counselor, clinical psychologists. We have also the dietitians, and also we have prosthetic and orthotic in the multidisciplinary team. So every week we have meeting between the team members of each. For example, for stroke team, okay, for the stroke team, we have all the doctors, the physios, the OTs. We meet once in a week and we discuss about the patient progress. Especially the patient is in the hospital, means the inpatient hospital, inpatient patient. So we discuss about the patients, how to progress, and how long that the patient need to stay for the rehabilitations, and when is the best time to discharge. And we completed our task or our goals during the first or 2 weeks of admissions. And after that, we say that the patient can discharge and continue at the outpatient program. Same goes to outpatient program. We also have multidisciplinary meeting at least once a week to discuss about outpatient patients, because we have two teams, different teams. For inpatient is different team, for outpatient is different team. So the keywords is we work as a team. Collaboratively, we work as a team, and our roles that we have to respect each other. We respect medical doctors' profession and management. It also respects our collaborative, such as occupational therapy. We have to discuss together, for examples, that how many hours, how many sessions, okay, what is the dose of the exercise, what is the frequency, intensity between two of us, physio and occupational therapy. And then we can refer the patient to the prosthetic and orthotic if needed. If the patient required ankle foot orthosis, or maybe the patient required any hip ankle foot orthosis, then we can discuss with the rehabilitation medicines, and we prescribe the equipment to the patient. So we work as the one team. The keyword is meeting. We have to meet every team members weekly. That's the system. Thank you.
Okay, thank you so much, Dr. Haitzir, for your thoughts. Dear participant, due to the limitation of time, we can only accommodate 2 questions for each speaker. However, you can still ask question for them, and we will send the list of your question to each speaker and share it to you in our WhatsApp group for the answer. Okay. Ladies and gentlemen, thank you so much for engaging in the first Q&A session. Now, I will invite all of you to take a moment to listen closely as our speakers share their final thoughts and reflections on today's topic. Dr. Pinson, would you like to start with your closing statement? Hello, Dr. Pinson, can you hear me?
Yeah, clear and loud. Excuse me.
Okay.
Yeah.
Ada yang jawab dia kok. Tapi, but I don't know. Okay, maybe Dr. Pinson had a technical problem. Let's move on.
Yes.
Let's move
Excuse me.
on to the second closing statement. Dr. Haidzir, could we hear your closing thoughts to wrap up the session?
Okay, thank you very much. So as the conclusions, physiotherapy is one of the profession that work together in the multidisciplinary approach team. We have to respect each other. We have to work together with other profession in order to think about the patient's recovery towards the the maximum recover that the patient can achieve. So other than that, hopefully that nowadays with the new coming technology, okay, we as a physiotherapy, we should integrate technology into our rehabilitations program, such as robotic, such as using the electrical stimulations, then other technology that might enhance the patient recovery, together with our hands-on technique in order to improve their mobility and functions. With that, thank you very much.
Okay, thank you, Dr. Haidzir, for your final thoughts. And we're back with Dr. Pinson. Would you like to start with your closing statement?
Yeah, thank you very much. First, I would like to thanks again to the committee for this fruitful seminar. I think stroke is a very complex condition. So patient with stroke need many things, need many aspects, not only nursing care, not only medications, not only physical therapies, not only social support, but he or she need many things. And to give the needs of the patients with stroke, we must work together with fruitful cooperation, with mutual respect and understanding. I repeat this sentence many times in my presentation: mutual respect and understanding. Understand everybody have their own expertise, their own rule. And if we perform that, we hope that our patient get a better outcome and good quality of life. Thank you very much.
Okay, thank you so much, Dr. Pinson, for your final thoughts. Ladies and gentlemen, thank you all for such an engaging and insightful session. We've truly learned a lot today from our expert speaker. And we're so grateful for the time and effort they dedicate to sharing their knowledge with us. As a small token of our appreciation, we would like to recognize each of our speaker with a certificate of appreciation. This certificate is a symbol of our gratitude for their contribution and value they've added to today's event. Let's begin with Dr. Saldita Slim Pinson, MCAS SPN from Bethesda Hospital, Indonesia. Dr. Pinson, your insights were invaluable, and we're so grateful to have you with us today. Please accept this certificate as a small thank you for your incredible contribution. Okay, next we would like to present a certificate to Associate Professor Dr. Muhammad Haidzir Manaf, PhD PT from University Teknologi Mara, Selangor, Malaysia. Dr. Haidzir, your was incredibly insightful, and we appreciate the depth of knowledge you've shared with our audience today. We're truly grateful for your time and expertise. Okay, once again, Dr. Pinson and Dr. Haidzir, thank you for being a part of this seminar. If you need to step away for another appointment or commitment, please feel free to leave the Zoom room at any time. We hope to have you join us again in the future. Thank you very much.
Thank you. Thank you once again for inviting me.
Yes, thank you. Have a lovely day.
Thank you. Bye.
Yes. Ladies and gentlemen, I believe you have picked on some valuable insight for the first plenary session. Now we're about to dive into our second plenary session, and we're thrilled to have you join us for what promises to be just as engaging and informative. This session we have Dr. MG Eni Mulyatsi, SCUP Nurse, MCUP SPKMB from National Brain Center Hospital Indonesia. She will present a topic about collaborative strategies to empower stroke recovery from a nurse perspective in Indonesia. Good morning, Dr. Eni.
Good morning. How are you?
Okay. How do you do?
I'm fine, thank you. Great.
Okay, thank you so much for taking the time to join us and for sharing your expertise today. We're about to begin the session, but first we have prepared a video CP that will walk you through her accomplishment and professional path. Okay, Dr. Annie, we're very excited to hear your thoughts and expertise on the subject. You have approximately 30 minutes to present your topic and have a Q&A session afterward. Ma'am, the floor is yours.
Okay, thank you so much for to moderator. I think due to the participant, almost of the participant are Indonesian, may I bahasa Indonesia?
Okay, sure. Well,
Ya, terima kasih kepada moderator. Karena saya lihat sebagian besar pesertanya dari Indonesia, mohon izin saya akan menyampaikan dalam bahasa Indonesia. Pertama, terima kasih kepada panitia yang telah memberikan kesempatan kepada saya untuk sharing tentang collaborative strategies to empower stroke recovery from a nurse perspective in Indonesia. Jadi kita akan diskusi tentang apa sih ya peran perawat untuk meningkatkan kohesivitas ya. Jadi soliditas dari tim stroke ini dalam penanganan pasien stroke. Jadi dari perspektif keperawatan. Outline hari ini saya mohon maaf tadi pagi tidak bisa mengikuti presentasinya yang awal karena saya ada kegiatan lain. Jadi mungkin nanti saya akan skip beberapa tentang medik ya karena saya rasa sudah disampaikan oleh medik tadi. Kemudian nanti yang akan saya bahas lebih ke peran perawat, tetapi mulai dari fase hiperakut sampai fase rehab. Mungkin secara singkat. Jadi teman-teman untuk di Indonesia sendiri perkembangan keperawatan untuk stroke ini sebenarnya dari mulai dari tahun 94-95. Waktu itu kami dikirim ke Australia untuk belajar tentang manajemen pasien stroke. Terus terang waktu itu sebelum berangkat kami memang tidak tahu ya, apa sih disfagia, apa itu stroke, bagaimana NISS, apa itu GCS. Kami sama sekali tidak diajarkan. Kemudian kami belajar 3 bulan di sana, dan setelah dari sana kami bertugas di unit stroke di RSCM, itu unit stroke yang pertama di Indonesia. Jadi adanya di RSCM. Jadi kami mulai mendesain apa sih pengkajian pasien stroke itu apa saja, diagnosis keperawatannya apa implementasinya, dan kami mengajarkan adik-adik untuk tentang keperawatan untuk pasien stroke. Nah, kita kira 10 tahun yang lalu saya dipromosikan jadi kepala bidang perawatan di Rumah Sakit PON. Ini rumah sakit khusus yang menangani pasien neurologi dan bedah saraf. Tetapi memang 70% pasien kami adalah pasien stroke. Kami juga secara rutin mengikuti Kongres Stroke Sedunia, ini terakhir di Singapura, kami ikuti tahun 2022. Itu fokusnya memang ada 2 ya. Yang pertama adalah untuk tata laksana hiperakut, yaitu terapi trombolisis. Kemudian yang kedua adalah fase rehab. Jadi rasanya memang tepat sekali topik hari ini kalau kita membicarakan tentang peran dari berbagai tim multidisiplin dalam tata laksana stroke. Pada bulan April yang lalu, saya mewakili Himpunan Perawat Neurosains Indonesia juga ikut dalam Stroke Expert Forum, yaitu membicarakan tentang tata laksana pasien stroke yang terupdate. Alhamdulillah keperawatan sudah masuk ya, jadi ada dokter dari neurologi, bedah saraf, rehab, kemudian radiologi, dan di sini saya mewakili dari Himpunan Perawat Neurosains Indonesia. Mengapa kita bicara tentang stroke? Yang pertama, stroke itu penyebab kecacatan utama pada dewasa. Kalau mengenai kematian, kadang-kadang pertama, kadang-kadang kedua, ya. Dan dokter dan perawat memiliki peran yang sentral pada fase hiperakut, yaitu fase untuk pada saat pemberian terapi trombolisis. Nah, menurut kami ini sudah terbukti ya bahwa kalau tata stroke itu dilakukan oleh tim secara terkoordinasi, itu hasilnya sangat baik, terutama khususnya adalah peran perawat. Stroke sendiri merupakan gangguan fungsi otak yang disebabkan karena kurang lancarnya aliran darah ke otak ya. Mudah-mudahan tadi sudah dibahas panjang lebar. Nah, hanya satu hal yang saya tekankan, apa peran perawat? Yang pertama adalah kita mempertahankan atau meningkatkan perfusi cerebral. Karena kita tahu untuk daerah otak yang sudah infak ini sudah tidak bisa dirubah, tetapi di daerah namanya penumbra. Penumbra ini daerah yang secara struktur masih normal, tetapi dia shock, tidak berfungsi karena memang kekurangan oksigen. Sehingga kalau kita pertolongan cepat melakukan reperfusi di daerah yang penumbra ini tidak akan jadi infak, sehingga mampu meminimalkan kecacatan akibat stroke. Tanda gejala stroke apa? Sebetulnya tergantung lokasi dan luasnya lesi. Misalnya kalau daerahnya, lokasi lesinya itu ada di daerah lobus occipitalis, pasien akan bisa mengalami gangguan visual. Atau pasien stroke-nya di daerah cerebellum, di mana kita ketahui fungsi cerebellum adalah untuk keseimbangan dan koordinasi otot. Sehingga pasien stroke bisa mengalami keseimbangan ya, nggak bisa duduk tegak, nggak bisa berdiri tegak, nggak bisa jalan secara simetris gitu. Karena pasien gangguannya adalah di cerebellum. Sehingga sebagai dasar, perawat harus memahami fungsi dari setiap bagian dari otak. Karena nanti kita akan belajar tanda gejala stroke ada tergantung pada lokasinya. Tanda gejala yang lain misalnya penurunan tingkat kesadaran, adanya gangguan hemiparise, ini kalau gangguannya pada daerah premotorik ya atau jarasnya itu bisa. Kemudian visual disturbance ini bisa terjadi kalau pada pasien lobus occipital ataupun pada jarasnya, misalnya pada optic chiasm, itu bisa juga menyebabkan pandangan kabur. Kemudian defisit memori, kemudian gangguan lapang pandang, ini apabila memang nervus 2-nya yang terkena, kemudian disfagia, gangguan menelan, defisit sensori, afasia. Afasia ini adalah gangguan komunikasi secara verbal, ini ada 2, jadi biasanya afasia motorik apabila gangguannya di daerah Broca, yaitu di daerah frontal kiri. Kemudian yang kedua adalah afasia sensorik, itu apabila gangguannya di daerah Wernicke lokasinya sekitar daerah temporal kiri. Jadi kita akan paham, oh ini pasien stroke lesinya di daerah hemisfer kiri, coba dikaji ada afasia atau tidak. Sedangkan disartria adalah gangguan dalam artikulasi kata. Kalau dengan kata lain bisa pelo atau celat gitu ya, atau cedal. Kemudian inkontinensia urin dan kejang. Nah, stroke adalah suatu kedaruratan otak. Jadi stroke adalah brain attack, suatu serangan otak yang setiap menit setiap detik sangat berharga bagi pasien. Secara umum, tataran stroke ini ada 4 fase. Fase hiperakut itu sebagian besar di pre-hospital, sedikit di IGD. Kemudian fase akut ini sedikit di IGD, mungkin sebagian lagi di unistroke atau di ICU. Fase subakut ini lebih banyak di ruang rawat inap yang untuk rehab. Dan fase rehab ini adalah di keluarga atau masyarakat. Nah, pada sesi ini, saya biasanya satu sesi itu hanya satu fase gitu ya. Tapi sesi ini memang saya akan secara skip gitu ada lebih cepat bagaimana sih peran perawat mulai dari pre-hospital, mulai fase hiperakut sampai rehab. Apa peran perawat yang paling penting adalah kecepatan waktu ya untuk di pre-hospital sampai di ruang IGD. Dan stroke ini merupakan suatu kedaruratan medik di mana intervensi dini mampu meminimalkan kecacatan, tetapi perlu koordinasi dari pasien, keluarga, dan tim stroke. Kenapa dari keluarga juga penting? Nah, seringkali pasiennya udah gejala stroke, tapi keluarga tidak paham, sehingga biasanya pasien dibawa ke rumah sakit sudah lebih dari 4,5 jam. Kita beberapa kali menemui pasien stroke di lapangan, di ruangan itu sudah 1 hari, sudah 2 hari, sudah 3 hari baru dibawa ke rumah sakit. Apalagi kalau tanda gejalanya itu memang pasien belum memahami ya. Misalnya pasien pandangan kabur gitu, dibawanya ke dokter mata. Ke dokter mata 3 kali nggak ada perubahan, nah baru ke rumah sakit, oh ternyata stroke. Demikian juga banyak tanda gejala lain yang masyarakat belum memahami. Sehingga nanti pentingnya sosialisasi kepada masyarakat tentang tanda gejala stroke dan bagaimana sikap yang seharusnya dari pasien dan keluarga. Stroke adalah suatu kedaruratan otak yang dimulai dari pre-hospital ya. Jadi ini menurut AHA memang tata laksana stroke ini dimulai dari masyarakat kembali ke masyarakat. Kenapa? Karena yang pertama adalah deteksi dini, itu pasti oleh masyarakat ya, oleh pasien keluarga. Seperti saya sampaikan tadi, wah ini apa ya, kok pasien kok ngomongnya ngaco ya, wah jangan-jangan dari jembatan mana ini, dari pohon besar mana, jangan-jangan kesurupan, nah gitu ya. Padahal memang pasien itu tanda gejala stroke awal, bisa aja dia mulai disorientasi, bisa mengalami gangguan komunikasi verbal, kan tiba-tiba tidak bisa ngomong gitu ya. Jadi peran masyarakat di situ. Sampai ke bagaimana kita inisiasi atau aktivasi petugas ambulan, memanggil petugas ambulan, kemudian segera dibawa ke rumah sakit, di IGD, ditangani oleh tim multidisiplin, sampai pasien kembali ke masyarakat. Jadi sebetulnya dari masyarakat kembali ke masyarakat, sehingga dari awal masyarakat ini harus kita libatkan. Pada fase yang pertama kita bicara fase hiperakut. Tadi ya, peran perawat dari perspektif perawatan apa? Ada namanya therapeutic window, jendela kesempatan. Apabila kita gunakan dengan baik, ya outcome pasien akan bagus gitu ya. Misalnya saja untuk terapi trombolisis intravena, itu gold standarnya, respon time-nya adalah kurang dari 4,5 jam. Jadi kalau lebih dari 4,5 jam ya tidak bisa lagi diberikan trombolisis intravena. Kemudian ada rantai keselamatan stroke, ada 7D, mulai detection, dispatch, delivery, door, data, decision, and drug. Jadi kita bahas satu persatu ya. Pertama adalah detection. Detection ini secara internasional yang digunakan adalah face. Face, wajahnya mencong nggak? Anjurkan pasien tersenyum ya. Mulutnya mencong nggak? Yang kedua arm, lengan atas. Anjurkan angkat kedua lengan, hitung sampai 10 hitungan. 1, 2, 3. Kalau dia kurang dari 10 detik sudah jatuh, itu artinya ada kelemahan separuh badan. Yang ketiga speech. Speech ini ajak pasien bicara. Bapak nama lengkap siapa? Tanggal lahir tanggal berapa? Apa yang dirasa? Sejak kapan ya? Apakah pasien bisa menjawab dengan baik? Apakah ada afasia? Apakah ada disartria? Selanjutnya, tiny time, secepatnya bawa ke rumah sakit, yaitu tanyakan dulu onsetnya kapan, Pak. Mulai lumpuhnya berapa mulai lumpuhnya dari jam berapa gitu ya. Kita tentukan dulu onsetnya dan time secepatnya bawa ke rumah sakit. Di beberapa negara sudah ditambah fast ini menjadi B-fast. Suara saya kenapa ya? Apakah terganggu suara saya? Apakah jelas suara saya? Moderator,
Jelas, Ibu. Baik.
ya. Bisa saya lanjutkan?
Silakan Ibu dilanjutkan.
Iya. Beberapa negara ditambah bifas. Selain tadi mulutnya menyong ya, kemudian separuh badan mengalami kelemahan, gangguan bicara. B-nya ini adalah balance, gangguan keseimbangan, dan ini adalah eyes, gangguan visual. Gangguan visual itu sebenarnya ada beberapa macam ya. Bisa pandangan kabur, bisa gangguan lapang pandang, bisa pandangan double gitu ya. Jadi gangguan visual ini bermacam-macam. Nah, di berikutnya tuh dispatch, segera hubungi PSC yaitu Public Safety Center. PSC ini adanya di Dinas Kesehatan Kota atau Kabupaten, tetapi di beberapa kota ada di bagian dari IGD di rumah sakit. Seperti di Mataram, di Lombok ya, di NTB, itu ada 2 rumah sakit yang punya PSC sendiri IGD-nya. Jadi apabila ada yang stroke langsung hubungi 119, makanya petugas PSC ini akan menghubungi ambulan, ambulan akan datang ya. Jadi PSC ini hanya menerima telepon saja. Menerima telepon, dia akan menghubungi supir ambulan. Nah, respon time-nya dari mulai PSC menerima laporan dari masyarakat sampai menghubungi ambulan itu kurang dari 90 detik. Jadi kurang dari 2 menit. Jadi harus cepat ya. Halo, ada stroke daerah Tebet. Oke, baik Bu, langsung dihubungi ambulannya. Ini ada stroke daerah Tebet, tolong dijemput ya gitu. Nah, mulai dari petugas ambulan dapat telepon dari PSC sampai datang ke rumah pasien itu kurang dari 8 menit. Nah, ini yang kendala memang kalau di Jakarta. Kita tidak bisa petugas dari dihubungi sampai datang ke rumah sakit karena adanya kemacetan ya. Mungkin di Jogja atau daerah lain yang tidak macet mungkin bisa ya kurang dari 8 menit. Di rumah pasien paling lama 15 menit harus segera dibawa ke rumah sakit. Nah, tetapi ada syarat, yaitu syarat petugas ambulan ini minimal adalah 2 orang perawat yang salah satunya memiliki SIM. Kenapa harus perawat? Selama di perjalanan di ambulan, itu perawat pertama tentunya memeriksa fasnya ya, pasien suruh tersenyum, angkat tangan, diajak ngomong gitu, fasnya positif atau tidak. Kemudian tanya onsetnya mulai kapan. Kemudian cek saturasi oksigen, berikan oksigen 2-3 liter per menit apabila saturasinya kurang dari 95%. Kemudian tinggikan posisi kepala 15-30 derajat. Monitor tanda-tanda vital. Untuk tekanan darah, periksa kiri kanan, kemudian periksa nadi apakah ada aritmia atau tidak. Apabila ada aritmia, lakukan EKG 12 lead. Apabila memang ada terbukti ada aritmia di situ, langsung pasang EKG monitoring di ambulan. Kemudian monitor juga nadinya, suhunya. Pasien stroke tidak boleh panas, sehingga apabila ditemukan pasien suhunya misalnya 39 derajat, langsung berikan analgetik. Kemudian cek tanda status neurologi yaitu minimal GCS, pupil, kekuatan otot. Cek kadar gula darah sewaktu. Obati apabila tinggi atau rendah. Kemudian pasang infus dengan cairan yang bersifat isotonik, misalnya NaCl 0,9%. Kemudian jangan berikan makan, minum, atau obat melalui oral sebelum Anda yakin bahwa pasien tidak ada disfagia. Jadi misalnya tadi pasiennya 39 derajat, Anda dicek dulu screening disfagia ada positif atau tidak. Apabila negatif, baru Anda boleh memberikan obat paracetamol via oral. Tetapi kalau memang ada disfagia, semua obat sementara harus diberikan lewat parenteral dulu. Kemudian petugas ambulan ini melakukan pre-notifikasi yaitu penjelasan awal kepada rumah sakit yang akan dituju. Nah, di Indonesia, Kementerian Kesehatan telah melakukan stratifikasi rumah sakit layanan stroke ada 4 tingkat mulai dari dasar sampai paripurna. Tapi yang dasar ini sudah dihilangkan ya. Jadi sekarang yang paling rendah adalah Madya. Madya ini adalah rumah sakit yang selain bisa trombolis intravena juga memiliki cath lab untuk neurointervensi. Yang utama memiliki kamar operasi dan dokter bedah saraf untuk melakukan intervensi vaskuler bedah. Sedangkan paripurna ini selain SDM-nya cukup, alat-alatnya lengkap, juga menjadi pengampu bagi rumah sakit yang di regionalnya. Nah, pre-notifikasinya apa saja oleh perawat yang di ambulan tadi, semua ya, data demografi pasien, misalnya perempuan atau laki-laki, umurnya berapa, hasil fasnya bagaimana, vital sign, saturasi oksigen, apakah ada kejang, apakah ada afasia, kemudian yang penting lagi adalah onsetnya berapa jam. Kemudian latar belakang penyakit, pengobatan yang diminum oleh pasien khususnya adalah obat untuk anti pembekuan darah ya, misalnya antikoagulansia. Kemudian hasil gula darah sewaktunya berapa, apakah diberikan insulin atau tidak. Dan yang paling penting adalah estimasi waktu sampai ke rumah sakit. Misalnya, dok ini saya petugas ambulans, saya akan ngirim pasien dengan stroke bla 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 tadi, akan sampai 10 menit lagi. Nah, misalnya kalau begitu, eh, dokter atau tim kesehatan yang di IGD sudah siap untuk menunggu di depan pintu ya, apabila memang ambulans sudah melakukan pre-notifikasi. Nah, mohon izin ini saya sampaikan contoh kalau ada notifikasi dari petugas ambulan, artinya ada penjelasan awal. Kita lihat sebentar videonya ini ya teman-teman semua ya.
Recently also dynamic history, evidence of amnesia, partial brief on right hand side. It's fine. It's fine. After we see through
Ya, di sini kita lihat bahwa door to city time itu hanya 5 menit dibandingkan apabila tidak ada pre-notifikasi itu bisa sampai setengah jam. Tapi karena keterbatasan waktu saya tidak menunjukkan video yang kedua ya. Nah, di door di IGD ini tergantung tadi apakah pasien diantar pakai ambulan atau tidak. Kalau pakai ambulan tadi bisa langsung ke CT scan tanpa melalui triase. Tetapi bila pasien datang dengan mobil pribadi itu harus dilakukan triase, yaitu harus diprioritaskan, lebih prioritas dibanding pasien dengan kasus lain, tapi sama prioritasnya apabila pasien mengalami serangan jantung. Jadi harus sama-sama dilakukan pengkajian, pengobatan secara cepat dan mulailah pendekatannya melalui multidisiplin. Nah, jadi di IGD ini sudah ada tim stroke. Tim stroke itu jadi ada dua, ada tim stroke IGD, ada tim stroke ambulan, ada tim stroke unit stroke. Nah, kalau untuk tim stroke di IGD itu minimal adalah profesinya 4. Dokter neurologi, perawat, kemudian radiologi dan laboratorium. Beda dengan tim stroke yang di unit stroke ya. Kemudian segera aktifkan kode stroke. Jadi kalau teman-teman perawat yang bertugas di bagian triase, ada 3 aktivitas yang dilakukan di triase. Yang pertama adalah pastikan fast dulu, ya, pastikan stroke atau bukan. Suruh pasien tersenyum, suruh angkat tangan kedua lengan, suruh diajak bicara, ada afasia atau tidak. Kemudian yang kedua adalah tanyakan onsetnya. Kemudian setelah tanyakan onsetnya, kalau memang kurang baru 1 jam yang lalu, langsung aktivasi kode stroke. Apa sih kode stroke? Kode stroke adalah suatu sistem yang mempercepat pelayanan pasien dengan stroke fase akut di IGD. Jadi kode stroke ini ada beberapa penelitian ya. Oh tidak ada, saya tidak sampaikan di sini. Jadi ada suatu penelitian tentang peran perawat.
Maaf Ibu untuk memotong.
Ya.
Kami ingin mengingatkan bahwa waktu yang tersisa adalah 5 menit.
Oke.
Begitu.
Oke. Ya,
Terima
saya
kasih,
lewat.
Bu.
Terima kasih banyak moderator. Jadi itu tadi kostum ya di triase dilakukan dengan cepat, kemudian ini pengkajian yang dilengkapi oleh perawat. Nah, saya nanti ingin sampaikan ke kerjasama. Jadi kerjasama tadi ya, ada dokter, perawat, laboratorium, dan bagian radiologi. Di IGD, di berikutnya decision, dokter harus memutuskan segera apakah pasien trombosis intravena enggak apabila onsetnya kurang dari 4,5 jam dan memenuhi kriteria inklusi dan eksklusi. Kemudian apakah pasien harus dilakukan microankle thrombectomy? Ini adalah apabila pasien terjadi penyumbatan pada pembuluh darah yang besar, itu bisa dilakukan neurointervensi. Ini ada kurang dari 24 jam. Kalau pasien harus operasi, misalnya pasien dengan stroke perdarahan ya, itu harus evakuasi hematom. Apakah tindakan surgical yang lain, misalnya dengan pemasangan EVD atau pemasangan lumbal drain atau pemasangan PP shunting. Kemudian apakah pasien harus masuk ICU? Untuk pasien stroke yang masuk ICU itu biasanya yang GCS-nya kurang dari 9 atau kurang dari 8. Nah, terapi trombolis sendiri adalah suatu obat untuk menghancurkan bekuan darah. Ini bisa diberikan tapi hanya terbatas waktunya, yaitu dengan onset kurang dari 4,5 jam. Ada panduan door to needle itu kurang dari 60 menit. Ini rekomendasi dari AHA, yaitu sebelum 10 menit dokter harus selesai periksa, triase ya. Kemudian dokter ketua tim stroke-nya selesai dalam waktu 15 menit. 25 menit pertama harus sudah dilakukan CT scan, hasilnya selesai dalam kurang 45. Dalam waktu kurang dari 1 jam, pasien harus sudah masuk obat untuk trombolisis intravena. Ini peran perawat pada terapi RTPA, ada identifikasi kontraindikasi, memastikan informed consent, periksa NIHSS, timbang berat badan, monitor TTV, monitor tanda gejala komplikasi yang paling penting ya, karena ada beberapa komplikasi. Karena waktunya mepet mungkin nanti bisa dibaca sendiri ya. Kemudian ini masuk ke unit stroke itu timnya lebih banyak lagi karena ada tim terapis ya, ada fisioterapi, terapis bicara, terapis okupasi, psikolog, ada medical social worker, ada dietitian, ada farmasi klinik. Jadi untuk stroke tim ini lebih luas lagi dibanding di IGD. Dan ini betul tadi ada Prof siapa dari Malaysia tadi bahwa harus ada tim meeting ya, minimal 1 minggu sekali. Oke, bagaimana strateginya supaya pasien recovery-nya berjalan dengan baik? Yang pertama bahwa pendekatannya multi tim tadi. Nah, namanya sudah tim, jadi tidak perlu konsultasi lagi. Kalau kami di unit stroke, fisioterapi itu akan datang langsung pada semua pasien stroke baru. Jadi dilakukan pengkajian, kemudian intervensi, baru seminggu sekali meeting. Jadi tidak perlu konsultasi lagi. Kemudian jangan lupa juga kita libatkan keluarga sejak awal ya, karena nanti toh pasien akan pulang ke rumah, sekali lagi saya katakan tadi, akhirnya kembali ke community gitu ya. Ini ada beberapa jurnal yang betapa pentingnya perawat ya untuk membantu pasien supaya smooth gitu ya, dari rumah sakit kembali ke rumah. Ini kita agak sulit memang. Misalnya length of stay untuk stroke ischemic itu kami adalah 5 hari. Sehingga kadang-kadang pasien merasa ini kok belum sembuh udah dipulangkan sih gitu ya. Padahal menurut analisa tim memang pasien sudah boleh pulang. Ini contoh pertemuan tim seminggu sekali, semua tim harus ikut. Nah, apa bedanya unit stroke dengan ruang lain? Ada beberapa intervensi khusus untuk pasien stroke di unit stroke. Yang pertama adalah mobilisasi dini, yang kedua stimulasi dini, yang ketiga manajemen swallowing, yang keempat bladder training, yang kelima discharge planning, yang keenam adalah patient and family education. Jadi ini harus dilakukan oleh perawat. Satu hal lagi adalah selain tadi, ke-6 kegiatan tadi adalah fever, sugar, swallow, atau FIS protokol. Jadi pasien stroke yang riwayat unit stroke ini harus dimonitor adalah suhu badannya, kemudian kadar gula darah, dan juga fungsi menelannya. Oke. Nah, ini satu masalah kita di Indonesia, bahwa pasien stroke kita tuh sebagian besar masuk dari IGD ya, mungkin ada 1, 2 yang masuk dari rawat jalan. Setelah dari IGD, pasien akan dirawat di unit stroke atau ICU, atau kemudian pindah ke rawat inap, bisa ke stroke ward, bisa stroke corner. Nah, kalau di luar negeri, pasien dari rumah sakit ini biasanya nggak langsung pulang ke rumah. Ada yang ke pusat rehab, ada yang community hospital, ada yang nursing home, ada palliative care. Tapi di Indonesia, semua pasien ini pulang ke rumah. Sehingga di sinilah masalahnya, kita harus menyiapkan keluarga. Sehingga kita beritahu keluarga, apa sih peran keluarga selama perawat pasien di rumah? Di antara lain adalah membuat pasien mandiri, kemudian juga memberikan privacy dan meningkatkan harga diri pasien. Jangan semua dibantu justru, karena pasien harus mandiri. Kalau pasien mandiri, dia rasa percaya diri meningkat. Dan fungsi keluarga yang kedua adalah terutama mencegah kecacatan, dan yang ketiga mencegah terulangnya stroke. Saya dan Dr. Erisa sudah menulis buku ini, yaitu Petunjuk Praktis Perawatan Pasien Stroke di Rumah. Ini sudah diterjemahkan juga ke dalam bahasa Malaysia. karena ini dengan gambar-gambar kartun dengan bahasa yang mudah dimengerti sehingga sangat bagus untuk caregiver ya, atau untuk keluarga ataupun untuk pasien yang merawat pasien stroke di rumah. Untuk rehabilitasi sedini mungkin akan lebih bagus. Kemudian ini persiapan stroke di rumah, jadi kita siapkan caregivernya, kita siapkan kamar mandinya, kamarnya harus bagaimana itu kita jelaskan dan tetap multidisiplin karena beberapa pasien mungkin masih memerlukan fisioterapi atau terapis okupasi atau terapis bicara di rumah. Kita ada beberapa tool
Maaf,
untuk
memotong.
ya.
Permisi, saya izin mengingatkan waktunya tersisa 1 menit.
Oke.
Oke.
Ya,
Terima kasih, Bu.
terakhir masalah keperawatan untuk pasien pulang ke rumah. Jadi memang agak berbeda dengan kasus lain. Kalau pasien stroke ini bisa masih mengalami gangguan multivisi, gangguan menelan, inkontinensi urin ya mungkin masih ngompol, gangguan memori, gangguan komunikasi verbal, risiko anjlok jatuh. Ini yang penting diberitahukan kepada pasien. Jangan sampai pasien jatuh di rumah karena sangat berisiko. Kemudian yang terakhir adalah risiko nyeri bahu ya, ini juga diajarkan kepada pasien dan keluarga bagaimana cara mencegah nyeri bahu. Ya mohon maaf Mbak moderator karena memang ini saya bicara dari fase hiperakut sampai rehab. Mudah-mudahan menambah wawasan rekan-rekan semua. Terima kasih atas perhatiannya. Waktu saya kembalikan kepada moderator.
Baik Ibu, terima kasih atas materi yang sudah dibagikan kepada kami. Mari kita melanjutkan ke dalam sesi tanya jawab. Dari pertanyaan pertama dari Ibu Mariam dari Yogyakarta dengan pertanyaan golden standard diagnosis stroke infarct adalah CT scan. Pada beberapa kasus begitu jelas gambaran infark pada kasus baru yang kurang dari golden periode. Bagaimana prospek ke depan dan apakah memungkinkan dengan pasien dengan angiografi cerebral? Apakah Ibu berkenan untuk menjawab?
Ya, terima kasih. Pertanyaan dari Mariam ya. Terima kasih pertanyaannya sangat bagus ya. Jadi memang ada perawat juga betul harus memahami beberapa pemeriksaan penunjang pada kasus neurologi. Untuk stroke ini memang gold standarnya adalah CT scan. Tujuan dari pemeriksaan CT scan adalah bukan untuk mengetahui ada infak atau tidak, tapi ada perdarahan atau tidak. Karena seringkali pasien stroke misalnya dia baru iskemik ataupun infak baru itu belum kelihatan di CT scan. Yang kita lihat adalah ada perdarahan atau tidak. Karena kalau tidak ada perdarahan, itu kemungkinan adalah stroke iskemik, sehingga bisa diperiksa lebih lanjut apakah pasien kandidat untuk terapi trombolisis intravena. Gitu ya. Tetapi beberapa rumah sakit swasta, mungkin dokter lebih senang dengan MRI. Tidak apa-apa. Yang penting waktunya. Karena waktu door to needle kita harus kurang dari 60 menit. Dan di rumah sakit pun sekarang sudah mampu rata-rata adalah 42 menit. Ini harus cepat, harus lebih cepat. Karena di Eropa Timur itu sudah bisa rata-rata 22 menit. Nah, kalau dengan MRI saya tidak yakin bisa sampai 20 menit gitu ya. Tapi kalau ada yang pakai, memang ada yang pakai MRI. Nah, bagaimana dengan penggunaan angiografi tadi? Angiografi ini ada 2. Yang pertama adalah CT angiografi. Ini dilakukan di ruang radiologi untuk mengetahui anatomis pembuluh darah. Jadi untuk mengetahui ada aneurisma enggak gitu, ada penyumbatan atau tidak. Yang kedua itu adalah digital subtraction angiografi atau DSA. Digital subtraction angiografi ini dilakukan di ruang ruang cath lab. Tujuannya sebenarnya sama juga untuk mengetahui anatomis pembuluh darah. Biasanya untuk mengetahui apakah ada AVM, apakah ada aneurisma, apakah ada stenosis gitu. Jadi tergantung indikasinya. Pasien indikasi dilakukan CT angiografi atau DSA apabila memang terduga pasien mengalami SAH. Jadi seperti indera bekti ya, misalnya itu kan bukan rahasia ya, indera bekti itu public figure. Indra bekti mengalami stroke perdarahan oleh karena pecahnya aneurisma itu diketahui dari pertama CT scan dulu, oh tidak setelah dilakukan CT scan baru dilakukan CT angiografi. Kira-kira begitu ya.
Baik Ibu, terima kasih atas jawabannya. Untuk pertanyaan kedua dari Bapak Edi Iswoyo dari Rumah Sakit Emmanuel dengan pertanyaan bagaimana memperdayakan peran keluarga dalam merawat pasien stroke di rumah.
Oke, terima kasih Pak Edi. Ini ya kalau mau jelaskan satu buku gitu ya. Jadi bagaimana secara singkat saja ya. Pertama adalah dari mulai di rumah sakit dulu. Di rumah sakit itu sudah kita bantu keluarga untuk menetapkan siapa caregivernya. Caregiver ini paling tidak dalam 3 bulan pertama pasca stroke ini selalu 24 jam bersama pasien. Jadi kita tanya apakah istrinya, apakah pasangannya, apakah anaknya, apa ponakannya gitu ya. Kadang-kadang sekarang banyak yang orang kaya anaknya sibuk semua, nggak ada yang rawat, oke kita namanya caregiver. Caregiver itu bisa berbayar, itu bisa dididik menjadi caregiver, kita berikan edukasi mulai dari rumah sakit. Edukasi apa? Banyak sekali, tergantung pada tanda gejala sisa yang pasien mau pulang. Misalnya, pasien mau pulang masih belum bisa jalan, ini masih kekuatan ototnya misalnya 2 gitulah ya, di bawah 2. Jadi pasien belum bisa jalan. Berarti pasien masih imobil di tempat tidur. Berarti edukasi yang kita berikan adalah bagaimana mobilisasi bertahap, bagaimana mencegah dekubitus, bagaimana mencegah pneumonia, bagaimana mencegah DVT gitu. Atau pasien pulang dia ada riwayat hipertensi, kemudian ada DM, ada riwayat penyakit jantung, sehingga edukasinya adalah bagaimana untuk mencegah recurrent stroke. Bagaimana cara mengontrol faktor risiko. Nah, di situ keluarga kita berikan edukasi segala hal tadi. Nanti kita ajarkan keluarga bagaimana kontribusinya. Misalnya Bapak anaknya 4 misalnya gitu ya. Tolong gantian ya Pak ya gitu. Bahwa Bapak ini nanti pasca stroke harus ada yang mendampingi. Misalnya pasien harus seminggu kemudian harus kontrol kan ya. Yang pertama itu. Yang kedua, Bapak ini harus minum obat-obatan misalnya untuk kontrol hipertensi, kontrol diabetes, dia harus minum obat. Berarti peran keluarga adalah memfasilitasi penyediaan obat. Karena ada kan yang pasien stroke lagi kenapa? Tidak minum obat karena apa? Tidak punya uang untuk beli, tidak ada keluarga yang menyiapkan. Atau misalnya di BPJS nggak ada yang ngantar ke puskesmas untuk ambil obat gitu. Jadi peran keluarga menurut saya Pak Edi sangat penting banget kita libatkan dari awal, mulai dari rumah sakit sudah dipanggil dulu oleh tim, kemudian diberikan edukasi berbagai hal menyangkut pasien, kemudian juga saya inginnya seperti Thailand ya. Thailand tuh bagus. Thailand tuh sudah ada sebenarnya kita juga harus bisa begini ya. Secara online itu kita dari rumah sakit bisa memonitor apakah sudah ada petugas puskesmas yang datang ke rumah gitu. Jadi untuk memastikan bahwa pasien ini termonitor dengan baik itu secara online. Nah, saya di Indonesia belum bisa ini. Misalnya kita pengen tahu nih, ini pasien ini udah berobat ke puskesmas belum ya? Sudah 3 bulan misalnya gitu. Kita nggak bisa. Belum ya mungkin ya. Jadi harus dibikin sistemnya. Tapi yang intinya adalah keluarga diberikan sejak awal dan diberikan edukasi sesuai dengan kondisi pasien. Mudah-mudahan menjawab ya Pak Edi ya. Sebetulnya karena waktunya terbatas jadi saya hanya bisa sebentar.
Baik, terima kasih untuk jawabannya Ibu. Selanjutnya kami ingin mendapat closing statement dari Ibu sebagai kesimpulan diskusi kami pada pagi hari ini. Kepada Ibu Eni, monggo closing statement-nya saya persilahkan.
Ya, terima kasih. Jadi rekan-rekan, Bapak Ibu semua yang sangat saya banggakan bahwa pendekatan dari perawatan stroke ini adalah multidisiplin. Jadi betul sekali bukan hanya perawat, tapi juga kita harus kerjasama dengan dokter, dengan tim terapis, dengan farmasi klinik, juga dengan dietitian. Pendekatannya multidisiplin dan juga yang kedua adalah libatkan keluarga sejak awal. Karena seperti ditanyakan oleh Pak Edi tadi, keluarga sangat berperan penting pada tata laksana berikutnya. Karena pasien stroke mungkin kalau iskemik hanya 5 hari di rumah sakit, perdarahan hanya 10 hari. Tetapi yang long life itu adalah di rumah. Sehingga sangat penting sekali kita melibatkan keluarga sejak awal dan memberikan edukasi yang memadai apa yang diperlukan oleh keluarga pasien. Demikian Mbak Moderator dan paling akhir stroke is a brain attack ya. Stroke adalah suatu serangan otak harus segera dibawa ke rumah sakit. Terima kasih.
Baik Ibu, terima kasih. Kami sungguh berterima kasih untuk ilmu yang sudah dibagikan. Sebagai ucapan terima kasih, kami ingin memberikan sertifikat sebagai wujud apresiasi kami atas insight yang sudah Ibu berikan. Kami berharap untuk mendapatkan insight lanjutan dari Ibu dalam kesempatan mendatang. Terima kasih Ibu.
Oke, terima kasih. Saya mohon pamit ya. Terima kasih banyak atas
Oke,
perhatiannya.
monggo Ibu, silakan persilahkan. 55. Ladies and gentlemen, I hope you are doing well and having great time so far. Okay, coming up next, we have Mr. Konwani Joseph Banda, PhD RNM from Kamusu Central Hospital, Malawi. Good morning, Dr. Joseph. Can you hear my voice, Dr. Joseph? Hello, Dr. Joseph. Can you hear my voice? Okay, I'm sorry. I think have you unmute your mic, sir? Because we cannot hear your voice. Hello, Dr. Joseph. Can you hear my voice? Have you unmute yourself because we cannot hear your voice? Let me remind to the participant, you are feel free to engage and ask question with the following format: your name underscore your country underscore speaker and underscore question. This is a great opportunity for you to engage and gain more knowledge. Okay, Dr. Joseph, can you mic check for me? Okay, we can see that you're still connecting. Okay. While we're waiting for Dr. Joseph to connect to the audio, dear participant, let me remind you that today's seminar promises to offer valuable insight into the critical role of collaboration between medical care, therapy, and collaboration between the medical care, therapy, and rehabilitation, and how a multidisciplinary approach can significantly enhance recovery outcome. And also, I will remind the participant that you are feel free to be engage with us to ask many questions with the following format: your name underscore country underscore speaker underscore question. You can type down on the chat box, on the comment, or when the Q&A session will be holding. Rejoin to the meeting. Okay, Dr. Joseph, would you trying to reconnect by rejoining the Zoom? Hopefully that it can connect to your audio. Okay. While waiting, we're going to. Okay, while we are waiting, I would like to kick things off with a brief video that will highlight some of our speaker key accomplishment and expertise they bring. Let's take a few moments to watch and then we will back to Dr. Joseph. Okay. Dr. Joseph, can you hear my voice? Okay, while we're waiting for Dr. Joseph to connecting the audio, let me remind you that today's event is a great collaboration between 7th Bethesda Yakkum Yogyakarta, co-hosted by 7th Jayapura. Also, I would like to take a moment to express our sincere gratitude to the following sponsor for their generous support who have made this event possible. They are Bethesda Hospital Yogyakarta, Ngestiwaluyo Hospital Parakan, Panti Wilasa Dr. Cipto Hospital Semarang, Emmanuel Hospital Klampok Banjarnegara, Sinar Kasih Hospital Purwokerto, Kriya Husada Sahabat Kesehatan Anda, and Dr. Julius Chandra Adi Purwadi, SPBA, Sus PP UAK, as a pediatric surgeon specialist at Bethesda Hospital Yogyakarta. Dr. Joseph, are you with us?
Yes, can you hear me?
Okay. How lovely to hear your voice. How are you today, sir?
I'm good, thanks. And how are you?
Okay, thank you so much for taking the time to join us and for sharing your expertise today.
Thank you.
Okay, we are very excited to hear your thoughts and expertise on the subject, and you have approximately 30 minutes to present your topic. The floor is yours, Dr. Joseph.
Okay, thank you. What happened again? Did I do? Where is this? Okay.
Dr. Joseph, do you have any trouble for sharing your screen?
No, just wait a little bit
Okay, thank you.
to let me share the screen. Can you see my screen?
Yes, sir, we can.
Okay. Good morning, everyone. Welcome to this presentation on quality of stroke care in Malawi, opportunities and challenges. My name is Dr. Kondwan Banda from Malawi, but currently I'm servicing at Taipei Medical University as a postdoctoral researcher. I would like to extend my gratitude to the organizing committee for inviting me to present at this conference. This presentation will focus on the stroke burden in Malawi and the existing care that we provide, the barriers and challenges that we have, and the recommendations that we can give for better care for the stroke survivors. So the outline of the presentation will be as follows. I'll start with the introduction of Malawi and go in depth on the stroke burden, the existing care that we are giving in Malawi, the challenges that we're facing, and the opportunities that we... Hello? And the opportunities that we have to enhance the stroke care in Malawi. So Malawi is a country in the southern eastern of Africa. It is bordered by Zambia to the west, Tanzania to the north and northeast, and Mozambique to the east, south, and southwest. Generally, it's a small country. And currently, we are around 21 million. And we are projected to increase to about 37 million by 2050. By age distribution, we have more, the population is around the age of, between the age of 15 to 16. So we are pretty a young nation. And for the life expectancy, there has been a significant improvement, moving from 45 years to from 2000 to 62 to 63 to around 2021. Generally, most of the causes of death are non-communicable diseases however, we still have a burden of HIV, and with the growing population, it is expected that the communicable diseases will increase, including the burden of stroke. So Malawi's healthcare system is three-tiered, provided by the government and the private sector. So it consists of the primary healthcare, secondary healthcare, and tertiary care. For the primary services, for the primary healthcare, we generally have community and rural hospitals maternity units, and general medical care that are provided at health center facilities. For the secondary care, we usually have specialized services such as laboratory work and rehabilitation wards, medical wards, and surgical wards at district hospitals. And for tertiary care, we have 4 central hospitals. So in these central hospitals, usually we have specialists that provide specialist care to the patients. Only those that are referred from the district hospitals. So stroke is one of the cause of death and disability in Malawi. The prevalence of risk factors include hypertension, diabetes, and HIV/AIDS, which further exacerbate the burden of stroke. Generally, there are very few specialized stroke units in Malawi, and these are primarily located in tertiary hospitals. Actually, only one central hospital is the one that has a specialized stroke unit. So many patients lack access to specialized care, particularly because most of the population is based in the rural areas. And this results in delayed treatment and poor outcomes. And this puts pressure on the families and the healthcare system as well. So the current state of stroke services in Malawi, most patients are managed in primary healthcare settings because we don't have many specialized stroke units. And in these primary healthcare settings, there are limited resources and limited expertise. Mostly the primary health care settings are done at health centers. And these centers are manned by a nurse and maybe a medical assistant who might not have specialized care in stroke. And mostly the nurse is also overwhelmed because he or she has to provide maternity care, under 5 care, and nursing care as well. So because these are low resource settings, the availability of advanced stroke treatments are not available, which compromises early management of the stroke, And due to the limited specialized stroke units, most stroke patients have to be sent to primary health care centers for initial management. However, the government is trying to train healthcare providers to ensure early detection of stroke and its management. Another issue is that the government is failing to employ nurses and the doctors that have been trained because of economic issues. So we still have a lot of barriers in the management of stroke. Okay. Another issue, to continue with the barriers, we have limited healthcare resources, including the shortage of trained professionals, lack of medication, diagnostic tools, which hinder the quality, the good quality stroke care. As I've just mentioned that the government is failing. There are some trained professionals, but the government is failing to employ them because of lack of funds. As such, stroke care is, in addition, most of the population is in rural areas, and these rural areas are hard to reach areas. Therefore, for the families to transport the patient or the government institutions to go and reach those places is too hard, which puts the lives of the stroke patients at a higher risk and increases the risk of mortality among these patients. Other barriers include because our health system is actually there's no insurance coverage. So the services that are provided at the district hospitals is not that good. So the patients have to opt for maybe private hospitals, which might be very expensive. So this makes many patients do not afford the treatment. As such, this results in delayed treatment and worsened health outcomes for the stroke survivors. In addition, due to high illiteracy levels, many Malawians lack the knowledge about the stroke symptoms, the risk factors, and the importance of early intervention. As such, many people are predisposed to or are at high risk of getting the stroke, which is poorly managed at the initial phase, leading to worse health outcomes. So to enhance better stroke quality care, the key strategies to improve care in Malawi include training workers in early stroke recognition. We need to establish standard treatment protocols and integrate stroke management in routine care. Therefore, we should make sure that those workers that work at the health centers, which are the primary healthcare settings, and which mostly are involved in the first patient contact, we make sure that the workers who are working there are trained in early stroke management. So they should be able to recognize the stroke and maybe refer the patient to the district hospital where they can receive specialized care. We should also ensure the standard treatment protocols are taught to those who are at the healthcare centers, which are the primary healthcare settings where most patients go there. In addition, we need to expand the access to specialized stroke care through maybe building more stroke units in the central hospitals and the district hospitals. And we need to improve our referral system to make sure that we have better health outcomes for the stroke survivors. In addition, as I've said, because the e-literacy levels are very low, are very high, so we need to ensure that the healthcare providers should be able to give better health education about stroke symptoms and the importance of early treatment. So we should increase public awareness campaigns that can help people recognize stroke symptoms so that they seek early treatment. Additionally, healthcare workers and other government institutions or non-governmental organization can conduct research and stroke surveillance to provide data that can be important to help inform policies. So it is through evidence-based that we can be able to design and have better stroke management for people in Malawi. In addition, as the country faces a lot of challenges, even though with the challenges, we should be able to seize the available opportunities and ensure that those people with stroke receive better care. We should ensure that we train our healthcare workers that work at the healthcare centers, which are the first point of contact for most of the patients who are based in the rural areas. We should also engage in multi-sectoral approach involving government, healthcare providers, communities, and other private sectors to ensure that we provide better stroke care and address stroke care challenges together. In addition, we need to invest in stroke care, build infrastructure. As I said previously, we have few specialized stroke units. Therefore, the government should take opportunity to build better infrastructure for stroke care, maybe add more specialized stroke units in other central hospitals, and in the future, maybe in the district hospitals, to ensure that most people are able to access better stroke care early. We should also encourage collaboration between the government, non-governmental organizations, and other stakeholders to ensure and improve the delivery of stroke care, which will lead to better stroke or health outcomes in this population. So the key recommendations: we need to invest in the human resource and infrastructure. We need to make sure that we have enough human resource in the healthcare centers that can be able to manage the stroke patients or be able to recognize the stroke symptoms early and refer the patients to better district hospitals that can manage the stroke early and improve the care. We need to develop national stroke care guidelines. So we make sure that each and every district, each and every healthcare center, each and every central hospitals follow the same guidelines to ensure a standardized management of stroke across the country. We also need to strengthen the referral systems. That means those in the primary healthcare settings should be able to send the patients to the district hospital faster. And those at the district hospitals should also be able to send the patients for specialized care at the central hospitals.
Okay, Dr. Joseph, I'm sorry to interrupt you, but I would like to let you know that we have 5 more minutes left. Thank you.
Okay. So other key recommendations is like we need to promote stroke prevention strategies. As I said, most of the we have a high illiteracy level. So we need to engage in more public awareness campaigns to ensure we give better stroke education so that people will be able to recognize the symptoms early and those people get early treatment for better outcomes. And in the near future, we need to introduce and encourage community-based stroke rehabilitation programs. This concludes my presentation. Thank you so much.
Okay, thank you for Dr. Joseph for sharing your expertise to us this morning. Please stay in this room because we will have a Q&A session after the third speaker session. Thank you. Okay, would you please end your share screen?
Oh, okay.
Okay, thank you. Dear participant, if you have any question for Dr. Joseph, you might type down your question in the chat box in the following format: your name underscore country underscore speaker underscore question, and he will be answering the question in the next Q&A session. Okay. Ladies and gentlemen, I'm delighted to ask you to join me in welcoming the fifth speaker, Dr. Biana Yvonne Bauk, PhD MSCN from Rotterdam Stroke Service, Netherlands. She will share her insight on model for enhancing the quality of life for stroke patients through a multidisciplinary approach in Netherlands. Good morning, Dr. Bianca. Can you hear me?
Yes, good morning.
Good
Can you hear me?
morning. How are you, doctor?
Yeah, I'm good. Thank you. A little bit sleepy because it's very early in the morning here.
What time is it in there?
At the moment, it's 5 o'clock in the morning.
Wow. We appreciate your time. Thank you so much for taking the time to join us and for sharing your expertise today. Okay, we're about to hear from Dr. Bianca, but before we begin, I would like to set the screen with a short video that will give you a snapshot of our speaker incredible journey and her impressive contribution to nursing field. Enjoy the video as we get ready to start the session. Okay. Thank you for the team, Dr. Bianca. We're very excited to hear your thoughts and expertise on the subject. You have approximately 30 minutes to present your topic. Okay,
Thank
the floor is yours.
Thank you for the introduction. I will share my screen. Just a second, please.
Sure, take your time.
Okay, can you see my screen?
Yes, we can see it.
Okay. Well, thank you for the introduction, and thank you for listening for me, and thank you so much for giving me the opportunity to present at this conference. I'm going to tell you something about the Rotterdam Stroke Service, about the project we are doing. Well, it's not a project anymore, it's CaRe as usual. The monitoring of cognition and depression with the stroke aftercare approach. There are no conflicts of interest and there was no sponsorship or commercial support given. The session objectives are to learn about the approach of stroke aftercare nurse to enhance quality of life and the advantage of data collection during the stroke aftercare project. I want to tell you something about the Rotterdam Stroke Service. It's a collaboration of different healthcare organizations, and collaboration results in a continuity of care. And the care is organized in a patient-centered way. Patients' needs are very important, but we cannot always meet patients' desires. Sometimes patients think they are in a hotel and ask the nurse for coffee, for massage, for everything they just want, but we cannot meet those desires. We give a lot of information to patients because if they have information, they are being able to make choices. We work together because of the quality and effectivity to reduce incompleteness of care. We want an optimal capacity use, efficiency and cost reduction, and we want, of course, optimize the quality of life of patients. And this is the Rotterdam Stroke Service. 17 organizations in the Rotterdam area, 7 hospitals, 9 rehabilitation centers with a specific stroke care unit. We have community care. I'm going to talk about that a bit more. The community care consists of nurses and therapists. We use pathways and we have an integrated care protocol. And our aim is to realize a high quality of life for every stroke patient in the Rotterdam area according to the most recent scientific standards. Deliver excellent fitting care in the right place at the right moment and delivered by the most skilled professionals. The stroke aftercare method, we started it with a practice-based research in 2010 because we thought there was no adequate care and support in the home situation after discharge. And we thought that would give a reduced quality of life. We saw disabilities and changing roles with patients and informal caregivers. And we saw caregiver burden. A lot of patients in the Rotterdam area had alcohol and medication abuse. We also saw mobility problems, social isolation, and foreign residents have a more riskful lifestyle but are harder to reach by our care professionals. If we look a bit deeper into it, after a stroke, patients are confronted with physical disabilities and changes in cognition and behavior, and this affects their quality of life. After discharge from hospital or rehabilitation center, the caregivers, the children, spouses are faced with multiple challenges. And we thought a specific stroke aftercare approach may be a solution to enhance quality of life of patients after stroke. So we started the project Stroke Aftercare with a task force within the Rotterdam Stroke Service. In this project phase, 3 organizations participated. From April 2012 to November 2013, we created a shared policy. We monitored our infrastructures within the Rotterdam Stroke Service, and we designed a research plan. This all was funded by ZonMW. It's a funding organization in the Netherlands. And the stroke aftercare approach consisted of outreaching nurse support by means of home visits. Our data collection was quantitative and qualitative. In the first phase, we had 169 patients with a mean age of 69 years. 54% of them was male. 85% had a stroke and 15% TIA. Patients were discharged home from hospital in 86% of the cases, and to the rehabilitation center in 5% of the cases, and nursing home 3%, remaining was 6%. The GP was involved in 90% of the patients, physical therapists 33%, speech therapist 9%, and psychologist or social worker was involved in 14% of the cases. In phase 2, we had 463 patients, of whom had mobility problems, independence 16%, cognition 15%, multitasking problems 15%, planning problems, coordination planning 15%, and almost half of the stroke patients had a lack of energy. 17% needed assistance with daily living activities, and they needed things to help them with daily life. In phase 2, we had manual data collection with subjective answers allowed, and the data we collected in an Excel sheet. In phase 2, we used a tablet computer. Every nurse involved in the stroke aftercare approach uses a questionnaire based on evidence-based instruments. And the name of that instrument is the assessment tool for long-term consequences after stroke. In Dutch, we call it the CaRe. It is a specific instrument for care in the community, and we use automatic data processing and storage in the cloud. And this is an example of the data collection, how it looks. They fill in the name of the nurse, questions on the tablet computer. The data may be sent by email to the nurses and also to the patients and their relatives. The nurses use a project code which allows for anonymity, and the data may be traced back to the hospital of origin. And only a specific nurse can trace the project code to a patient, and nobody else can. This is an example of one of the measurements within the instrument. This is the geriatric depression scale with 15 items. And for example, are you in general satisfied with your quality of life? Have you lost interest in activities or hobbies? Do you feel your life is empty? And all the answers are in yes or in no. The stroke aftercare method approach consists of a care pathway. It follows the route from patients from hospital to rehabilitation. It concerns the acute phase in the hospital, and patients are then referred to the community care organizations, and patients receive outreaching nursing support consisting of home visits. And the nurses collect demographic data, assess functional abilities, and use standardized checklists. If we look at the situation at this moment in 2025, 40 nurses are involved in stroke aftercare team, and this is a team of different organizations, so different care organizations, home care organizations. And they work as a self-steering team because hierarchical, they fall under their own organization, but they work as a team for the Rotterdam Stroke Service. In this way, we offer structured stroke aftercare. And we think it helps us to have a better awareness in the integrated care service. We have the anonymized data in the cloud. And at this moment, we have a very large database because we collect data from 2012 until 2025. And each patient is monitored for 2 years. Every year, we have 3,000 stroke patients in the Rotterdam Stroke Service. So you can imagine that we have a large database. 65% of the patients receive follow-up. So 35% of the patients we cannot reach. Because we have such a large database, it offers opportunities for a national database and input for better care, better finance. So we try to involve also the insurer. The assessment tool for long-term consequences after stroke is a large instrument, and it's used to monitor patient status after stroke, and it consists of 17 items. So it's an assessment tool. Within it, there are more measurements relating to 12 domains of activities of daily life: social activities, cognition, communication, psycho-emotional status, fatigue, secondary prevention, medical consumption, medical condition, caregiver strain, and provision of information. And the outcomes of the questionnaire are stored in a database. I'm going to zoom in on a few outcomes, and those are the CLCE and the GDS. The CLCE is the checklist for cognition and emotion, and it consists of 22 Likert scale items which are related to cognition, emotion, and behavioral problems, and 2 additional items. And GDS 15 is a geriatric depression scale, and it is used to determine if patients have depressive feelings. For this analysis, I use data of 4 stroke aftercare nurses, and it concerned 614 patients in a period of 18 months, and 250 patients show potential issues and require further investigation for depression or anxiety. From the previous 250 patients, 85 patients are at risk for depression, 87 patients are at risk for anxiety, and 78 patients need no further follow-up. So 65% of our patients receive follow-up after hospitalization with the stroke aftercare approach. However, we think that every stroke patient should be referred for stroke aftercare. But unfortunately, 7 hospitals and 9 rehabilitation centers not always refer the patient to the stroke aftercare method. And also a significant number of patients does not consent with follow-up. So they refuse to have the stroke aftercare nurse at their home. Therefore, our results may be subject to selection bias. Furthermore, the ACAS is a long questionnaire and may cause exhaustions or patients to lose interest when the nurse is at their home. However, it is crucial to use standardized questionnaires to work evidence-based and maintain consistency of care. On the other hand, nurses tend to skip questions or simplify them to make it more easy for the patient. In conclusion, an evidence-based way of working shows to be demanding for patients and nurses. However, patient follow-up and measuring the long-term consequence after a stroke is crucial to provide targeted advice and information to the patient. Follow-up is needed to be able to refer patients to other healthcare professionals, such as a physical therapist or occupational therapist or psychologist. Recognizing and treating depressions in patients who have experienced a stroke is important for their well-being and quality of life. Since depression is accompanied by psychological suffering, and since depression has a negative effect on the recovery of a patient with stroke. I would like to give you the opportunity to have questions, and thank you for your attendance.
All right, thank you to Dr. Bianca for sharing your expertise to us this morning. Please stay in this room because we will have a Q&A session afterwards. Thank you, ma'am. Dear participant, if you have any question for Dr. Bianca, you may type down your question in the chat box in the following format: your name _ country _ speaker _ question. She will be very happy to answer the question. Okay, ladies and gentlemen, we will open the floor to the question from our audience. The committee has collected question for our 2 wonderful speakers. I will start for Dr. Joseph. The question is from Ms. Dewi from 7th Bethesda with the question: how to maximize recovery in post-stroke patient and support for post-stroke patient and family. Would you be so kind as to respond to this question, Dr. Joseph?
Hello,
Yes.
can you hear me?
Yes, I can hear you loud and clear.
Okay. Thanks for that excellent question. I think to maximize stroke care in the post-recovery, we need a comprehensive rehabilitation plan such that we need to ensure that we institute early interventions and ensure that we have a multidisciplinary team, because these patients will present with different problems which require different specialists. So as such, we would want that to maximize the care, each and every discipline, like the nurses have to do their part, the doctors have to do their part, the physiotherapists have to do their part, the nutritionists have to do their part. In addition, we need to have better medical management. We also need to provide psychosocial support for their families, because these patients don't come there in the hospitals alone. So we don't need, we need to educate and train the families about stroke, so that in the future they can be able to recognize the signs early and be able to send the patient to the hospital early. We also need to counsel and offer emotional support to their family. We could also encourage support groups, such that in these support groups, those who are affected are able to share their experiences, and from those experiences they can be able to learn something and move forward. In addition, we need to encourage lifestyle modification. That means they have to be on a healthy diet, continue with the exercise, and as healthcare workers, we need to monitor their progress. In this way, we might be able to maximize the better stroke care in the post-recovery. I don't know if I've answered the question.
Okay, thank you so much for your insight. And the second question is from Mrs. Lydia from 7th Bethesda. And the question is, why does HIV/AIDS become one of the highest reduction of stroke in Malawi? Dr. Joseph, could you provide your insight on this?
I think because we in Malawi have a high prevalence of HIV, and I think HIV becomes a comorbidity. So that means if we reduce the rate of HIV, which is one of the risk factors for the stroke, that means we'll have fewer patients that will experience a stroke. So by targeting the HIV, that means we'll have fewer cases or for stroke. That's how I can answer the question. I don't know if that answers.
Okay, thank you for your answer, Dr. Joseph. The upcoming question is for Dr. Bianca. The question is from Miss Maria Frani. Are you from Indonesia? With the question is, I'm incredibly impressed with the extensive journey it took to establish the Rotterdam Stroke Service and the comprehensive system it encompasses. Could you share what you consider to be the key determining factors, or perhaps what significantly accelerated the process in building such a system, especially with regard to long-term care for stroke patients?
Yes, thank you for that question. What is really, really, really important are the people. So people involved in stroke care should be prioritized to the stroke patients, should know each other. We were founded in 1997, so we have a long history. And at first we tried to enhance the stroke care. So in the acute phase, the treatment for stroke patients. And then we figured that patients were staying long in the hospitals. So they have a length of stay of 30 days because they were sick, they were ill, so they needed to stay in a hospital. And then we saw that new patients were coming. We didn't have any place for other patients. So we collaborated with other organizations, rehabilitation centers, to refer patients as fast as they could from hospital to the rehabilitation. And that's where the Rotterdam Stroke Service started, in that collaboration. We started with 5 organizations, and nowadays we have 17 organizations. But our capital is in human, in the people that work in the Rotterdam Stroke Service, so the individuals.
Okay, thank you for your answer, Dr. Bianca. And the second question is coming up from Mrs. Anggita from RSK Ngestiwaluyo. With the question is, what is meant by structured post-stroke care? Dr. Bianca, could you provide your insight on this?
Yeah, the structured post-stroke care concerns the pathways we use. So it's structured by means of a pathway. So every nurse knows what to do in the situation of a stroke patient. So if she comes at home with a patient, she follows a kind of a protocol. Of course, she delivers individual care, but she follows a protocol. And in that protocol, she uses the ACAS, and afterwards it is analyzed, and then she has a follow-up of the patient of 2 years, in which she, on several moments in a year, comes at the home of a patient, makes phone calls to the patient. So we deliver care in those 2 years. On basis of individual needs. So sometimes patients need a contact every week, and some patients are doing fine and they need a contact every 2 months. So that's the structure we have.
Okay, thank you for explaining your structure with us. And the last question we have, interesting question from nurses. With the question is, you mentioned that each stroke patient is monitored for 2 years. Would you please tell us the strategies to reach those patients? Because we have in Indonesia frequently lost contact with stroke patient after they done caring in the hospital.
Yes, we collaborate very well within the organization. So when a patient is admitted to the hospital, we have their name, their telephone number, their email address. Then patients are being discharged from hospital within mostly 5-6 days. Then they are clinically stable and they can go to home or to the rehabilitation center. And at that moment, the stroke aftercare nurse receives an email with the name and the telephone number of the patient. So at that point, she knows who the patient is, which is going home. And within 3 days, she will call the patient at home to ask them how they are doing, if they need some assistance or if they're doing well. And well, 65% of the patients, we can make that call and we find them, and they will have the opportunity for the nurse to come to visit at their home. And in 35% of the cases, we don't have a telephone number, or they have been moving out, or the hospital has forgotten to give the telephone number to the stroke aftercare nurse. And in about 15 to 20% of the cases, when the stroke aftercare nurse calls the patients, he says, okay, I'm doing very fine. You don't need to come at my home because I'm okay. And then the stroke aftercare nurse leaves her telephone number at the patient, so he can call her anytime he wants.
Okay, thank you, Dr. Bianca, for your question. I'm sorry for your lovely answer. Dear participant, due to the time limitation, we're only accommodate 2 questions for each speaker. However, you can still ask question for them and we will send it list of questions to each our speaker and share the answer to you in our WhatsApp group. Ladies and gentlemen, thank you so much for engaging in the third Q&A session. Now I will invite all of you to take a moment to listen closely as our speaker share their final thoughts and reflection on today's topic. Dr. Joseph, may I invite you to deliver your closing statement? I'm sorry, Dr. Joseph, you're still on unmute. Could you please, okay.
Okay, distinguished guests, Dr. Bianca and all the audience. As we come to close of this important conference on enhancing stroke care, I want to sincerely thank you for your active participation, insightful discussion, and the questions that you provided to us. Your unwavering commitment to improving the lives of stroke patients. Let us take this opportunity to engage in a multidisciplinary approach, value the strength we have in unity to ensure the progress, strengthening of primary care for stroke patients, expanding specialized stroke care, improving public awareness, and integrating innovative AI or telemedicine in our healthcare system. It is important to acknowledge the role that the multi-sectoral approach, where clinicians, policymakers, researchers, and communities should work hand in hand to translate in better stroke outcomes. As we live today, let us carry with us a renewed sense of purpose and shared responsibility to advocate for better stroke care services. Let us invest in research, strengthen our healthcare systems, and most importantly, prioritize the well-being of the healthcare workers and the stroke patients and the families, so that we have better stroke outcomes. Thank you.
Okay, thank you, Dr. Joseph, for your wonderful conclusion. And to conclude, Dr. Bianca, could you share your final thoughts with the audience?
Yes, my final thoughts. I guess it's a recommendation. I think as a healthcare worker, you need to invest in relationships, not only with your patient, but also with other healthcare workers. And I think that has made the Rotterdam Stroke Service such a strong integrated care service, because we invest in relationships with others. We have 17 organizations in the stroke service in Rotterdam. And a lot of people know each other. So in the rehabilitation center, they know the nurses at the stroke care unit. And that makes it easy to reach them. If they have questions about a patient, it makes it very easy to call the nurse in the hospital. Hi, how are you doing? We invest in social activities to better collaborate. We have symposia, we have meetings, we have lunches and dinings, just to collaborate better, to know each other, to build relationships. I think that is key. And I want to thank everybody for listening to me, and I wish everyone a very, very beautiful day. Thank you.
Okay, thank you so much for the closing statement, Dr. Bianca. It's been such a fantastic session, and we cannot thank our speaker enough for their insightful contribution. As a token of our appreciation, we would like to present each of our speaker with a certificate of appreciations. This is just a small way to recognize your invaluable contribution to today's event. Our heartfelt thanks goes to Dr. Joseph for his incredible insights and contribution. The certificate we're presenting is just a small way of acknowledging the effort, the passion, and the knowledge you brought to us. We look forward to the possibility of collaborating with you again in the future. The last but not least, we want to express our sincere gratitude to Dr. Bianca for her invaluable contribution. This certificate is a small token of our appreciations for the dedication, the passion, and the expertise you've shared with us today. We truly hope that we will have the chance to work with you again in the future. Once again, Dr. Joseph and Dr. Bianca, thank you for being a part of this seminar. Much appreciated. Ladies and gentlemen, what a fruitful seminar it has been. We've heard from some truly insightful speakers who highlighted the importance of a holistic, integrated approach to stroke care, from a medical intervention to therapy and rehabilitations. It's clear that the collaboration across disciplines is key to improving outcome for stroke patients and enhancing their quality of life. The synergy of medical care, therapy, and rehabilitation is not only crucial in the acute stage of recovery, but also in the long-term management of stroke patients. I would like to extend our sincere thanks to each of our speakers for their expert contribution and for providing such a thorough overview of these vital topics. Your insights are truly inspiring, and I'm sure they spark many important ideas for future action. As we conclude this session, I would like to thank all of you, the audience, for being such an engaged audience. We encourage you to continue the conversation started here as we move forward in this seminar. Now, I will hand it over to our MC. Back to you, Yeko.
Thank you so much, Lydia, for expertly guiding us through today's plenary session. We greatly appreciate your efforts in making the session smooth and engaging. You are really the chosen one. Dear participants, let me remind you once again to fill out the evaluation form. The link is provided in the chat box. Don't forget to fill it out soon because it will be closed within 1 hour after the seminar is ended. The materials from all the speakers and its certificates will be sent via WhatsApp group in the form of a Google Drive. And it will be open for a week before we close the access, so please make sure you won't lose it. Let me remind you that the e-certificate is only given to the participants who attend the seminar from the beginning to the end. If the participant does not get a certificate, please contact the committee by attaching a screenshot of the registration and evaluation that has been filled in. Also, let me remind you to complete the learning and fill out the evaluation in Pelataran Sehat. Ladies and gentlemen, today's event is a great collaboration between 7th Bethesda Yakkum, Yogyakarta, co-hosted by 7th Jayapura. Also, I'd like to take a moment to express our sincere gratitude to the following sponsors for their generous support who have made these events possible. They are Bethesda Hospital, Yogyakarta, Ngesti Waluyo Hospital, Parakan, Panti Wiloso Dr. Cipto Hospital, Semarang, Emmanuel Hospital, Klampok, Banjarnegara, Sinar Kasih Hospital, Purwokerto, Gria Husada, sahabat kesehatan Anda, Dr. Julius Chandra Adipurwadi, SPPA, SUSPPUA, a pediatric surgeon specialist at Bethesda Hospital, Yogyakarta. Dr. Handoyo Pramusinto, SPPSK, a neurosurgeon at Bethesda Hospital, Yogyakarta. Dr. Rizaldi Taslim Binson, MKes SPN, a neurologist at Bethesda Hospital, Yogyakarta. Dr. Prasetyo Trikuncoro, SPS, a neurologist at Emmanuel Hospital, Klampok, Banjarnegara. Dr. Dias Irawan Prasetya, a general practitioner at Bethesda Hospital, Yogyakarta. Bebek dan Ayam Ungkep Pawan Ayu by Dr. Muhammad Rifan Maulana, SPA, a pediatrician at Emmanuel Hospital, Klampok, Banjarnegara. We are deeply grateful for your partnership and we look forward to continuing this journey with you. Ladies and gentlemen, coming up next, we have a door prize giveaway sessions. As a token of appreciation for your participations, we will be awarding a few lucky participants with some cool prizes. We know that many of you have been engaging with us throughout the event, and we want to thank you for your enthusiasm and presence. So, congratulations for Miss Maria Frani Ayu from Stikes Waka Insan Banjarmasin, Miss Margareta Rina from Bethesda Hospital, Yogyakarta, and Mr. Danarso from Bethesda Hospital, Yogyakarta. Once again, congratulations for all the winners. So don't forget to contact Millennia on WhatsApp at 088200681859 for further information. Let me repeat, for all the winners, please contact this number on WhatsApp at 088200681859 for further information. Dear participants, I would gladly inform you that after this plenary seminar is over, we will continue to the parallel sessions. The parallel sessions will be in the same Zoom room, so make sure you to join us as we are going to start at 12:45. Ladies and gentlemen, thank you all once again for being part of today's enriching seminar. We hope you found the discussion insightful and that you're living with valuable knowledge and inspirations. So before we conclude, let us take a moment to reflect and give thanks for the opportunity we've had to come together and learn from one another. Let us bow our heads and join me in our closing prayer. Let's pray. Heavenly Father, we come before you with grateful hearts, thanking you for the wisdom shared and the connections made today. We pray for your continued guidance as we move forward in our respective journeys. May we apply the knowledge we've gained to make a positive impact in the lives of others, especially those in need. We ask for your blessings on everyone here and for the success of all the future endeavors. In Jesus' name, amen. Ladies and gentlemen, as we come to the close of today's event, we'd like to capture this special moment and take a virtual group picture to remember our time together. So if you're able, please turn on your camera and show your beautiful face and let's gather for a quick screenshot. We'll give everyone a moment to get ready. The documentation crew, are you ready? Please wait for a moment while you're preparing for your cameras. All right, on the count of three. 1, 2, 3. Cheese! Let's move on to the second slide. Open your camera. Get yourself ready. Give your best smile. Smile. So please smile. We need your smile. All right, on the count of three. 1, 2, 3. Cheese! There you go. Let's move on to the next slide. Open your camera, get yourself ready again. Smile, please don't forget to smile. Your smile is expensive here. On my comment. 1, 2, 3, cheese! Perfect. Thank you very much. Dear participants, don't forget to access the link of evaluation as we said, as stated on the screen. Please kindly scan and fill the evaluation form. Ladies and gentlemen, we have come to the very end of this seminar. On behalf of the committee, I would like to thank of all of our speakers, co-hosts, sponsors, and participants for making today's seminars such a success. We hope you found the discussions insightful and inspiring. I'm Yeko, your host for today, asking for apologize for any misconduct I did that may cause discomfort for you. It's been a pleasure having you all with us today, and we look forward to seeing you at the future events. And until then, take care and stay safe. God bless you all.
CaRe Bethesda Yakkum, Yogyakarta is a private health science institute located in the heart of Yogyakarta. It belongs to Yakkum, Christian Foundation for Public Health, one of the largest health service foundations in Indonesia. CaRe Bethesda Yakkum, Yogyakarta has been through substantial change for more than a century. Founded as Zeningsen Kenhuis Petronella Health Service in 1889 and changed into an Institute of Health Science in 2009, CaRe Bethesda Yakkum has become a center of health science education. Caring with love is our core value, in which we are committed to it to guide our practice in ethical and sustainable ways in conducting the learning process and community development. Currently, our status of accreditation of BAN PT is B, and we will continue to improve the quality of our education as a health science institute with high competitiveness. CaRe Bethesda Yakkum, Yogyakarta has 3 study programs accredited B by LAM-PTKes. They are Diploma 3 of Nursing, Bachelor of Nursing, and Nursing Profession Education. Being part of global educational institution, Our students come from different provinces in Indonesia. Even some of them are international students. All of the students are given the same opportunity to learn and to accept knowledge. The diversity in ethnic groups, religions, and cultural background makes us 7th Bethesda Yakkum Yogyakarta a multicultural campus. 7th Bethesda Yakkum Yogyakarta is committed to provide learning opportunities to talented students to its extensive scholarship programs. They are KIP Kuliah, Ristek Dikti, Dikpora DIY, Eka Cipta Foundation, Bank BRI, Bank BPD DIY, and PT Astra Honda Motor. The education quality assurance is proven by the outstanding result of the National Nursing Competence Examination with the graduation rate of more than 90%. A various facility and service for the students provided by 7th Bethesda Yakkum Yogyakarta is as follows. The Nursing Laboratory. The laboratory is designed in such a way to replicate the clinical scenario in hospital. The room is divided into medical surgery nursing, pediatric nursing, maternity nursing, mental health nursing, and community nursing. Utilized with a complete and up-to-date simulation aids with a ratio of a set of 8 for 10 people, students have equal chance to make use of the nursing laboratory based on the schedule made. With 6,405 books, 22 accredited journals, 27 international journals, 3 science magazines, 23 proceedings, and more than 40 ebooks and 798 final tasks. 7th Bethesda Yakkum Yogyakarta provides students lounge as a comfortable environment for daily learning and discussion to enhance the students' learning productivity. 7th Bethesda Yakkum Yogyakarta also provide rooms for problem-based learning discussion. The lecturers and the students can actively discuss through their PBL material to build up their knowledge autonomously. Furthermore, along with the dynamic development of information technology, 7th Bethesda Yakkum Yogyakarta has applied online learning method so that students can learn anywhere at any time. Another facility offered for the students is the computer lab and also language lab. 7th Bethesda Yakkum Yogyakarta provides dormitory for female students. A strong referral network with public hospitals, private hospitals, and foundation hospitals has been built for the students' clinical practice placement. 7th Bethesda Yakkum Yogyakarta has some numerous achievements. The students' achievements, both local and international. 7th Bethesda Yakkum Yogyakarta also facilitates the students to develop their interest and talent by having student sport clubs such as futsal club, martial art, basketball, table tennis, chess, badminton, and volleyball club. Students' art clubs such as dancing club, choir, band and acoustic, and traditional music club. To embody the vision of 7th Bethesda Yakkum Yogyakarta, that is to produce healthcare professionals with global competitiveness, the students involve themselves in some international events such as Student Exchange Program, Joint Summer Programs, Operation Pacific Angels, and Intercultural English Program. 7th Bethesda Yakkum Yogyakarta has built a strong network with hospitals and institutions of various fields all over Indonesia. We also continue to collaborate and build synergy with higher education institutions all over Asia Pacific. Through its Career Center, 7th Bethesda Yakkum Yogyakarta provides assistance to students and alumni with planning a career, developing job search strategy, and more. The center also facilitates in-campus recruitment for the students. Within less than 3 months, 95% of the students are recruited, and the rest apply for civil servant and pursue higher education. Our loyal stakeholders are hospitals belong to Yakkum and some private hospitals. We are also realizing the need to implement soft skill training to shape the excellence of graduates' quality, such as decision making, shaping inner beauty, service of excellence, how to succeed a job interview, career path, and table manner.
Alasan saya memilih 7th Bethesda Yakkum sebagai tempat menimba ilmu karena saya mendapatkan ilmu yang selalu update tentang keperawatan. Selain itu, saya juga diajarkan tentang tata krama dan perilaku yang baik. Itu adalah modal utama kita saat terjun dan berbaur dengan masyarakat nantinya.
Alasan saya memilih 7th Bethesda Yakkum Yogyakarta dalam menimba ilmu, karena 7th Bethesda Yakkum Yogyakarta merupakan institusi pendidikan yang memiliki banyak lahan untuk praktek mahasiswa. Selain itu, 7th Bethesda Yakkum Yogyakarta juga bekerja sama dengan banyak rumah sakit dalam rekrutmen pegawai. Sehingga, lulusan 7th Bethesda Yakkum Yogyakarta cepat dalam mendapatkan pekerjaan. Dan lagi, di 7th Bethesda Yakkum Yogyakarta memiliki banyak peluang beasiswa yang mudah untuk kita peroleh.
Alasan saya memilih 7th Bethesda Yakkum Yogyakarta sebagai tempat menimba ilmu, yaitu kampus ini memiliki segudang prestasi baik akademik maupun non-akademik, dan yang pastinya SDM-nya pun sangat berkualitas. Di 7th Bethesda Yakkum Yogyakarta saya mendapat begitu banyak ilmu yang dapat saya terapkan di keseharian saya. Saya bangga menjadi bagian dari 7th Bethesda Yakkum Yogyakarta.
Alasan saya memilih 7th Bethesda Yakkum Yogyakarta sebagai tempat saya menimba ilmu adalah dikarenakan visi dan misi dari 7th Bethesda. Di 7th Bethesda saya mendapatkan banyak sekali bekal yang saya bawa hingga sampai saat ini saya bekerja, yaitu manajemen time dan peduli penuh kasih. Dan saya sangat bangga sekali menjadi salah satu keluarga dari 7th Bethesda Yakkum Yogyakarta.
Alasan saya memilih 7th Bethesda sebagai tempat menimba ilmu karena merupakan sekolah keperawatan Yayasan Kristen untuk Umum yang berada di Yogyakarta dan dekat dengan tempat tinggal orang tua saya. Juga memiliki fasilitas rumah sakit sendiri, fasilitas di kampus lengkap, dan juga adanya pengajar-pengajar yang profesional di bidangnya.
Come and join us of becoming an excellent healthcare professional who is caring with love.
Saya Estianingrum, Ketua Sekolah Tinggi Ilmu Kesehatan Jayapura, mengucapkan selamat datang di Sekolah Tinggi Ilmu Kesehatan Jayapura.
samurai mind, they can't be.
Di dunia yang penuh kesibukan ini, terdapat keindahan dalam momen-momen sederhana. Inilah kisah Ahmad, seorang ayah yang menghadapi cobaan terbesar dalam hidupnya. Ahmad adalah pilar kebahagiaan bagi keluarganya. Dalam senyumannya terdapat kehangatan dan cinta tak terbatas. Namun, takdir memilih jalannya sendiri. Dalam sekejap, hidup Ahmad dan keluarganya berubah. Di ruang darurat rumah sakit, takdir mereka bergulir di ujung keputusan medis.
Dari hasil pemeriksaan yang sudah dilakukan, Pak Ahmad arahnya ke serangan disebut. Karena waktunya masih cepat, kita akan lakukan pertolongan dengan cepat juga. Nanti arahnya kita CT scan kepala terlebih dahulu untuk mengetahui stroke yang jenis apa. Setelah itu baru kita bisa tahu tindakan apa yang akan kita ambil.
Di antara detak jantung yang tak menentu, keluarga Ahmad menunggu dengan harapan yang tak terhumus. Dalam kelemahannya, Ahmad menemukan kekuatan yang luar biasa dari cinta keluarganya. Setiap detik menjadi hadiah berharga.
Selamat pagi, Pak.
Selamat pagi, Suster.
Bagaimana kabar hari ini?
Alhamdulillah, luar biasa.
Perjalanan pemulihan bukanlah lintasan yang mudah. Namun, setiap langkah yang diambil adalah bukti keberanian dan ketekunan. Dan di antara kita, di dalam ketenangan hati, terdapat keajaiban yang tak terduga. Keajaiban cinta, keberanian, dan harapan. Itulah kekuatan keluarga.
Peserta mendapat pesan melalui email dari Rumah Sakit Kristen Ngesti Waluyo untuk mengisi formulir medical check-up. Hari kedua setelah pendaftaran, peserta mendapat pemberitahuan melalui WhatsApp untuk perjanjian medical check-up. Peserta datang ke Rumah Sakit Kristen Ngesti Waluyo melewati pintu masuk lobi, kemudian petugas akan mengarahkan peserta untuk menuju ruang pertemuan. Peserta memasuki ruang tunggu. Selanjutnya petugas melakukan pengecekan ulang dokumen pendaftaran medical check-up yang telah diisi peserta melalui aplikasi. Setelah dokumen pendaftaran lengkap, peserta akan diantar oleh petugas untuk dilakukan pemeriksaan laboratorium darah. Selanjutnya peserta akan dilakukan pemeriksaan radiologi meliputi head CT scan, USG, foto toraks, maupun foto panoramik. Selain itu dilakukan pemeriksaan treadmill, dan pemeriksaan elektrokardiografi. Peserta dapat menikmati layanan pemeriksaan dan konsultasi dengan dokter umum, konsultasi dengan ahli gizi, pemeriksaan dan konsultasi dengan dokter spesialis THT, serta pemeriksaan dan konsultasi dengan dokter gigi. Setelah menyelesaikan pemeriksaan, peserta akan menerima notifikasi mengenai hasil melalui email. Demikian, alur medical check-up di Rumah Sakit Kristen Ngesti Waluyo.
Di Booking.com, kami mengerti perjalanan bisa lebih panjang dengan
Soalnya kemarin meneh kan di beberapa
Cek, cek. Selamat siang. Assalamualaikum warahmatullahi wabarakatuh. Shalom, Om Swastiastu, Namo Buddhaya. Salam kebajikan bagi kita semua. Saya ucapkan selamat datang kepada yang terhormat, kepada juri, dan kepada seluruh peserta oral and poster presentation. Puji syukur kehadirat Tuhan Yang Maha Esa atas berkatnya sehingga kita semua dapat berkumpul dalam rangkaian pelaksanaan oral and poster presentation dengan tema Enhancing the Quality of Life for Stroke Patients through a Multidisciplinary Approach, Synergy of Medical Care, Therapy in Rehabilitation. Sebelum kita memulai acara ini, marilah kita berdoa menurut keyakinan kita masing-masing. Berdoa dimulai. Berdoa selesai. Para hadirin, perkenankan saya membacakan peraturan dalam kegiatan ini. Ada peraturan dari oral presentasi ini yang pertama, setiap peserta harus hadir tepat waktu, selambat-lambatnya 10 menit sebelum acara dimulai. 2. Peserta wajib mempresentasikan hasil karyanya sendiri dan tidak dapat diwakilkan. Apabila peserta tidak dapat menghadiri presentasi, maka dianggap mengundurkan diri. Ketiga, artikel disampaikan secara oral presentasi sesuai dengan template yang telah diberikan. 4. Presentasi menggunakan bahasa Indonesia yang baik dan benar. 5. Isi presentasi harus bebas dari sara, kekerasan terhadap golongan tertentu, ataupun pornografi. 6. Presentasi akan dilakukan secara online dengan menggunakan aplikasi yang terbagi menjadi 2 break room sesuai pembagian dari panitia. 7. Dalam satu ruangan Zoom hanya terdapat 1 juri, 1 MC, 1 tim peserta, dan 1 timekeeper, serta peserta yang akan melakukan oral presentasi. 8. Jika dalam waktu 2 menit, peserta yang dipanggil tidak menjawab atau open mic, maka peserta yang bersangkutan akan berada pada urutan presentasi terakhir. 9. Pada saat presentasi, peserta diharapkan menggunakan laptop atau PC dengan menyalakan kamera saat memasuki ruang Zoom dan wajib mematikan audio jika tidak dipersilakan untuk berbicara. Menggunakan koneksi internet yang stabil dan baik, menggunakan pakaian yang sopan saat kompetisi berlangsung, berada di ruangan dengan cahaya terang dan suasana ruangan yang hening. 10. Tiap peserta memperoleh waktu 12 menit dengan alokasi waktu, presentasi 8 menit, masukan atau tanya jawab 4 menit. Jika waktu presentasi habis, peserta wajib menghentikan presentasi. 11. MC akan memberikan kode kepada peserta jika waktu tersisa 3 menit dan ketika waktu sudah habis. 12. Segera setelah presentasi, dewan juri atau peserta selain presentator dipersilakan untuk mengajukan pertanyaan secara oral. Kemudian, setiap peserta diharapkan untuk langsung menjawab semua pertanyaan. Jika waktu sudah habis, peserta wajib mengakhiri jawabannya. 13. Apabila peserta mengalami gangguan koneksi, maka harus segera menghubungi panitia. Jika tidak melakukan konfirmasi kepada panitia, maka waktu akan dianggap terus berjalan. 14. Peserta wajib mempersiapkan share screen PowerPoint secara mandiri dan memonitor sinyal supaya stabil. 15. Peserta wajib mengetahui nama akun Zoom-nya pada format nomor nama peserta. Contoh, Evi masuk room 1 dengan nomor urut 4, sehingga nama akunnya adalah R1_04_F. 16. Keputusan juri bersifat mutlak dan tidak dapat diganggu-gugat. 17. Sertifikat oral presentasi akan diberikan kepada peserta atau autor yang melakukan presentasi. Baiklah, selanjutnya saya akan memperkenalkan juri dan membacakan urutan peserta. Untuk break room 1, juri dengan Ibu Katarina Hatri Istiarini, S-Cup NSM Cup, SP Cup MB, PhD NS. Yang pertama ada Ance Sialagan. Kedua ada Arselina Prayaninda. Ketiga ada Agnes Monica Puspita Ningtyas. 4. Elvin Agustian Nugroho. 5. Doni Armando. 6. Fernandes Agus Setia Putra. 7. Budiawan Adi Prakoso. 8. Erwina Wahyuniarti. Untuk Break Room 2, juri dengan Bapak Dwi Nugroho Heri Saputro, Skep NSM Kep, SPKep MB PhD NS. Yang pertama ada Agatha Christie. Yang kedua ada Ivana Melinda. Ketiga ada Mia Talenta. 4 ada Aurelia Lintang Alis Kurniawati. 5 ada Gian Liswari Aditya Siwi SST FTR MFIS. 6 ada Dian Prihatiningsih. Dan 7 ada Marta Tenowie. Baiklah, kepada seluruh peserta dapat memasuki break room sesuai dengan yang telah ditentukan dan diinstruksikan kepada seluruh peserta untuk tetap berada dalam break room masing-masing dan dapat kembali ke main room sesudah mendapat instruksi dari panitia.
CaRe Bethesda Yakkum, Yogyakarta is a private health science institute located in the heart of Yogyakarta. It belongs to Yakkum, Christian Foundation for Public Health, one of the largest health service foundations in Indonesia. CaRe Bethesda Yakkum, Yogyakarta has been through substantial change for more than a century. Founded as Zeningsen Kenhuis Petronella Health Service in 1889 and changed into an Institute of Health Science in 2009, CaRe Bethesda Yakkum has become a center of health science education. Caring with love is our core value, in which we are committed to it to guide our practice in ethical and sustainable ways in conducting the learning process and community development. Currently, our status of accreditation of BAN PT is B, and we will continue to improve the quality of our education as a health science institute with high competitiveness. CaRe Bethesda Yakkum, Yogyakarta has 3 study programs accredited B by LAM-PTKes. They are Diploma 3 of Nursing, Bachelor of Nursing, and Nursing Profession Education. Being part of global educational institution, our students come from different provinces in Indonesia. Even some of them are international students. All of the students are given the same opportunity to learn and to accept knowledge. The diversity in ethnic groups, religions, and cultural background makes us CaRe Bethesda Yakkum, Yogyakarta a multicultural campus. CaRe Bethesda Yakkum, Yogyakarta is committed to provide learning opportunities to talented students to its extensive scholarship programs. They are KIP Kuliah, Ristek Dikti, Dikpora DIY, Eka Cipta Foundation, Bank BRI, Bank BPD DIY, and PT Astra Honda Motor. The education quality assurance is proven by the outstanding result of the National Nursing Competence Examination with a graduation rate of more than 90%. A various facility and service for the students provided by CaRe Bethesda Yakkum, Yogyakarta is as follows. The Nursing Laboratory. The laboratory is designed in such a way to replicate the clinical scenario in hospital. The room is divided into medical surgery nursing, pediatric nursing, maternity nursing, mental health nursing, and community nursing. Utilized with a complete and up-to-date simulation aids with a ratio of a set of 8 for 10 people, students have equal chance to make use of the nursing laboratory based on the schedule made. With 6,405 books, 22 accredited journals, 27 international journals, 3 science magazines, 23 proceedings, and more than 40 ebooks and 798 final tasks. CaRe Bethesda Yakkum, Yogyakarta provides students lounge as a comfortable environment for daily learning and discussion to enhance the students' learning productivity. CaRe Bethesda Yakkum, Yogyakarta also provide rooms for problem-based learning discussion. The lecturers and the students can actively discuss through their PBL material to build up their knowledge autonomously. Furthermore, along with the dynamic development of information technology, CaRe Bethesda Yakkum, Yogyakarta has applied online learning method so that students can learn anywhere at any time. Another facility offered for the students is the computer lab and also language lab. CaRe Bethesda Yakkum, Yogyakarta provides dormitory for female students. A strong referral network with public hospitals, private hospitals and foundation hospitals has been built for the students' clinical practice placement. 7th Bethesda Yakkum Yogyakarta has some numerous achievements. The students' achievements, both local and international. 7th Bethesda Yakkum Yogyakarta also facilitates the students to develop their interest and talent by having student sport clubs such as futsal club, martial art, basketball, table tennis, chess, badminton, and volleyball club. Students' art clubs such as dancing club, choir, band and acoustic, and traditional music club. To embody the vision of 7th Bethesda Yakkum Yogyakarta, that is to produce healthcare professionals with global competitiveness, the students involve themselves in some international events such as student exchange program, joint summer programs, Operation Pacific Angels, and intercultural English program. 7th Bethesda Yakkum Yogyakarta has built a strong network with hospitals and institutions of various fields all over Indonesia. We also continue to collaborate and build synergy with higher education institutions all over Asia Pacific. Through its Career Center, 7th Bethesda Yakkum Yogyakarta provides assistance to students and alumni with planning a career, developing job search strategy, and more. The center also facilitates in-campus recruitment for the students. Within less than 3 months, 95% of the students are recruited, and the rest apply for civil servant and pursue higher education. Our loyal stakeholders are hospitals belong to Yakkum and some private hospitals. We are also realizing the need to implement soft skill training to shape the excellence of graduates' quality such as decision making, shaping inner beauty, service of excellence, how to succeed a job interview, career path, and table manner.
Alasan saya memilih 7th Bethesda Yakkum sebagai tempat menimba ilmu karena saya mendapatkan ilmu yang selalu update tentang keperawatan. Selain itu, saya juga diajarkan tentang tata krama dan perilaku yang baik. Itu adalah modal utama kita saat terjun dan berbaur dengan masyarakat nantinya.
Alasan saya memilih 7th Bethesda Yakkum Yogyakarta dalam menimba ilmu karena 7th Bethesda Yakkum Yogyakarta merupakan institusi pendidikan yang memiliki banyak lahan untuk praktek mahasiswa. Selain itu, 7th Bethesda Yakkum Yogyakarta juga bekerja sama dengan banyak rumah sakit dalam rekrutmen pegawai. Sehingga, lulusan 7th Bethesda Yakkum Yogyakarta cepat dalam mendapatkan pekerjaan. Dan lagi, di 7th Bethesda Yakkum Yogyakarta memiliki banyak peluang beasiswa yang mudah untuk kita peroleh.
Alasan saya memilih 7th Bethesda Yakkum Yogyakarta sebagai tempat menimba ilmu, yaitu kampus ini memiliki segudang prestasi baik akademik maupun non-akademik, dan yang pastinya SDM-nya pun sangat berkualitas. Di 7th Bethesda Yakkum Yogyakarta saya mendapat begitu banyak ilmu yang dapat saya terapkan di keseharian saya. Saya bangga menjadi bagian dari 7th Bethesda Yakkum Yogyakarta.
Alasan saya memilih 7th Bethesda Yakkum Yogyakarta sebagai tempat saya menimba ilmu adalah dikarenakan visi dan misi dari 7th Bethesda. Di 7th Bethesda saya mendapatkan banyak sekali bekal yang saya bawa hingga sampai saat ini saya bekerja, yaitu manajemen time dan peduli penuh kasih. Dan saya sangat bangga sekali menjadi salah satu keluarga dari 7th Bethesda Yakkum Yogyakarta.
Alasan saya memilih 7th Bethesda sebagai tempat menimba ilmu karena merupakan sekolah keperawatan Yayasan Kristen untuk Umum yang berada di Yogyakarta dan dekat dengan tempat tinggal orang tua saya. Juga memiliki fasilitas rumah sakit sendiri, fasilitas di kampus lengkap, dan juga adanya pengajar-pengajar yang profesional di bidangnya.
Come and join us of becoming an excellent excellent healthcare professional who is caring with love.
Saya Estianingrum, Ketua Sekolah Tinggi Ilmu Kesehatan Jayapura, mengucapkan selamat datang di Sekolah Tinggi Ilmu Kesehatan Jayapura.
Killer body samurai mind thinking. Samurai mind thinking. 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 Killer body samurai mind thinking.
Di dunia yang penuh kesibukan ini, terdapat keindahan dalam momen-momen sederhana. Inilah kisah Ahmad, seorang ayah yang menghadapi cobaan terbesar dalam hidupnya. Ahmad adalah pilar kebahagiaan bagi keluarganya. Dalam senyumannya terdapat kehangatan dan cinta tak terbatas. Namun, takdir memilih jalannya sendiri. Dalam sekejap, hidup Ahmad dan keluarganya berubah. Di ruang darurat rumah sakit, takdir mereka bergulir di ujung keputusan medis.
Dari hasil pemeriksaan yang sudah dilakukan, arahnya ke serangan stroke. Karena waktunya masih cepat, kita akan lakukan pertolongan dengan cepat juga. Nanti arahnya kita CT scan kepala terlebih dahulu untuk mengetahui stroke yang jenis apa. Setelah itu baru kita bisa tahu tindakan apa yang akan kita ambil.
Di antara detak jantung yang tak menentu,
presentasi. Di sini sekarang saatnya untuk mengumumkan presenter terbaik. Namun dari itu penilaian dari presentasi oral dan juga poster diperoleh dari yang pertama, presentasi oral dan nilai artikel oleh reviewer. Yang kedua, presentasi poster dan nilai artikel oleh reviewer. Baik, ini adalah oral. Untuk juara oral presentasi room pertama, yaitu juara 3 oleh Erwina Wahyuniarti. Selamat saya ucapkan. Untuk juara kedua, Agnes Monica Puspita Ningtyas. Selamat saya ucapkan. Untuk terbaik pertama yaitu Elvin Agustian Nugroho. Selamat saya ucapkan. Kemudian untuk juara oral presentasi di room kedua, untuk terbaik ketiga yaitu Aurelia Lintang Alis Kurniawati. Selamat saya ucapkan. Untuk terbaik kedua yaitu Mia Talenta. Selamat saya ucapkan. Untuk terbaik pertama yaitu Gian Liswari Aditya Siwi SST FTR MV. Selamat saya ucapkan. Selanjutnya adalah pembacaan nilai terbaik oral presentasi. Untuk juara 3 ada Mia Talenta. Selamat saya ucapkan. Untuk juara kedua ada Elvin Agustian Nugroho. Selamat saya ucapkan. Untuk juara 1 ada Gian Liswari Aditya Siwi SST FTR MV. Selamat saya ucapkan. Baiklah, selanjutnya kita akan melakukan foto bersama. Dimohon untuk kepada seluruh peserta dan Dewan Juri untuk mengaktifkan kamera. Apakah sudah siap semuanya? Baik, kita akan mengambil gambar. 1, 2, 3, senyum. Satu kali lagi. Satu kali lagi mungkin? Ya. 1, 2, 3, senyum. Oke. Doa, doa. Penutup. Baik, para hadirin, sampailah kita pada penghujung acara. Marilah kita tutup kegiatan ini dengan berdoa. Berdoa dimulai. Berdoa selesai. Terima kasih saya ucapkan kepada para juri dan peserta oral and poster presentation, sehingga acara ini dapat terlaksana dengan baik. Saya Lucia Silvana sebagai MC oral presentation hari ini pamit undur diri. Terima kasih, Tuhan memberkati. Ya mohon maaf, di sini kita akan maaf sebelumnya tidak jadi selesai. Kita akan membacakan poster terbaik terlebih dahulu. Baik, untuk pemenang poster presentasi terbaik ketiga adalah Limbong Dameira Cynthia C. Selamat saya ucapkan. Untuk juara harapan kedua adalah Priani Haryanti S Cup NSM Cup PHD. Selamat saya ucapkan. Untuk juara harapan 1 ada Delantin Mona Lisa. Selamat saya ucapkan. Untuk juara 3-nya ada Ana Maria Violeta Narmada. Selamat saya ucapkan. Untuk juara keduanya ada Dewi Jati Satyani. Selamat saya ucapkan. Untuk juara pertamanya ada Maria Frani Ayu Andaridia. Selamat saya ucapkan. Baik, untuk saat ini benar-benar saya akan tutup kegiatan oral presentasi kita pada hari ini. Saya sebagai MC kembali pamit undur diri. Jika ada salah kata saya mohon maaf. Terima kasih, Tuhan Yesus memberkati. Selamat sore.